As I go over these topics, I'm going to actually stop and kind of point out what the boards are really interested in. Sometimes they're interested in something which is not very clinically important. But what I'm going to do is at least try and highlight those points as we go through. And some of the pearls or clinical pearls are actually totally intertwined between these topics. So these are the topics which we'll be covering one by one. And as I told you, I would be actually highlighting some of the clinical pearls and some board-related pearls, which you need to focus on as you are going through these topics. So in the interest of time, let's just get started with it. So the first thing which we're going to cover is acute kidney injury. Very common topic. Few questions are definitely going to be on your boards related to it. But what is acute kidney injury? And I think over the last 10, 15 years, there's been a lot of new definitions coming out. Most of these definitions are actually being more used for research purposes rather than clinical. And I can tell you, as far as clinical medicine is concerned, the definition still remains it's sudden loss of kidney function over hours to days, and it is commonly reflected by rise in nitrogenous waste, right? Blood urea nitrogen and creatinine. Again, there are official definitions like serum creatinine going up by zero point 0.3 over 48 hours, or doubling of creatinine, or increase in creatinine of 1.5 times the baseline. But I think for clinical and practical purposes, if you just remember that it's this sudden loss of kidney function, which is reflected by increase in nitrogenous waste, including BUN and creatinine, that would be enough to go forward. And this second part is kind of controversial, a decrease in urine output, because part of the definition initially used to be, or which was proposed, was if your urine output is less than 0.5 milliliters per kg for 6 hours. And again, if you look at this definition, and there was a pretty sarcastic kind of review in British Medical Journal, pretty much each and every physician will be in acute kidney injury, right? Because you're not drinking while you're working, and it can easily happen. So urine output is controversial. We're gonna stay out of it. So sudden increase in nitrogenous waste, BUN, and creatinine. The definition and how you approach acute kidney injury actually hasn't changed ever since your med school days, right? The diagnostic schema of how you think about acute kidney injury is exactly the same. So if somebody comes in with acute kidney injury, you got to think about, is this a problem with pre-renal AKI? That means, is the blood not coming to the kidney at the right pressure or right volume, right? The kidney is fine, but the blood is not coming to the kidney at either the right pressure or the right volume. So that is pre-renal AKI, and we shouldn't even call it actually AKI, but I'm going to still stick with this schema because that's what is proposed. Because if you actually biopsy this kidney, all the structures are fine. This is almost a hemodynamic compromise. It's not actually injury because it's very reversible. The post-renal is there's some problem with obstruction or some problem to the urinary flow so that the urine is actually backing up, and that is causing injury. So these two are very easy. So blood is not coming to the kidney, or the urine flow is impeded, and that's back pressure, and there's injury. So that's post-renal. And what is left is the kidney itself. And then you got to actually go back and remember what is there in the kidney, right? Again, I'm going to take you back to your medical school days. If you're looking at a slide of a kidney, what's there in the kidney, right? There are these 4 structures. There's the glomerulus. If glomerulus is injured, it's acute glomerulonephritis, and we'll be talking more about it as we move forward, right? If glomerulus is the heart of the nephron, right? The filtering unit. If that's injured, it's acute glomerulonephritis. The glomerulus is connected to the tubules, right? That's where the ultrafiltrate, which ultimately becomes urine flows. So if that's injured, it's acute tubular necrosis. Surrounding the glomerulus and the tubules is the interstitium. If that is injured, it's acute interstitial nephritis. And intermingled in the interstitium is blood vessels. There are multiple blood vessels. So if there's something going around there, there's acute vascular syndromes, and we'll be talking about those too. So if you just remember what's there in the kidney, glomerulus is acute glomerular nephritis, tubules, acute tubular necrosis, interstitium, acute interstitial nephritis, and then there's blood vessels. There's vascular syndromes related to it, right? That's pretty much it, how you approach the differential diagnosis, right? So now, if a patient is actually being admitted to a hospital with acute kidney injury and you were trying to bet, I'm like, I don't want to know all this. What if I had to just actually guess what would be the proportions? Actually, if you just took a wild guess, 50% will be ATN. I'm talking about patients who are going to be admitted for AKI. 30% are going to be pre-renal, so 80% out of 100 are covered, and 10% are going to be post-renal. So 90 out of 100 are going to be these three diagnoses. And then, of course, boards loves these, but actually, like everything, they like to focus on the rest 10. I have no idea why, but that's what they like to focus on. So we'll be going into those 10% which I've left out in detail too. Right? So 90% are going to be either pre-renal, ATN, or obstruction. Now, if you understand this slide, half of my job is done because I would be covering 80% of your AKIs just based on this slide. So one thing which is going to keep on coming again and again is what happens if you become volume depleted? If you're having diarrhea, if somebody gives you too much diuretics, if somebody stabs you in your heart and you're bleeding away to glory, what happens? As soon as you become volume depleted, 3 hormones get activated. One of the, and I have to apologize, it's early in the morning, but you can't teach nephrology without going into a little bit of physiology. So as soon as your volume depleted, 3 hormones get activated, and those 3 hormones are sympathetic system, so your norepinephrine, epinephrine is going to be upregulated because your heart needs to pump faster, your blood vessels need to contract to maintain a normal blood pressure. So sympathetic system is activated in all of us as soon as we become volume depleted. The 2 other big systems which are activated are renin, angiotensin, aldosterone system. And the third one is ADH, anti-diuretic hormone, because you want to actually retain all the water and sodium possible. So sympathetic system, renin-angiotensin system, and ADH are activated. So just keep that in the back of your mind as we go along. So now this is a rough cartoon of what's happening in your kidney. So this is your glomeruli. This is the afferent arteriole, which brings blood to the glomeruli. So afferent for arrival, A for arrival, so that's the afferent arteriole. And efferent arteriole is the blood vessel which takes the blood away from the glomerulus, right? E for exit. So the blood is exiting. And this is where the filtration takes place, and nicely, a med study has labeled this yellow. So this is what ultimately becomes urine, right? This ultrafiltration goes through tubules and it ultimately becomes urine. So initially, when you become volume depleted, right, when you're bleeding, or if you have what I call as effective circulating volume depletion, that means that's what happens with heart failure when your heart is not pumping enough blood, right? The baroreceptors are thinking it's a volume depleted state. So when the baroreceptors don't feel enough pressure, they activate the same systems as you would activate when you are actually volume depleted, right? So the magic initially happens in these 2 vessels, right? Your kidney is a very smart organ. As soon as you become volume depleted, it still wants to maintain the normal GFR here, right? So what it does is angiotensin 2 from the renin-angiotensin system constricts the efferent arteriole. So this becomes constricted, and afferent arteriole becomes dilated from sympathetic system and prostaglandins, right? So what's happening is kidney is trying to maintain a normal GFR by constricting the efferent and dilating the afferent arteriole. So this is what happens in me and you. That's why me and you can actually have a lot of volume depletion and we don't go into acute kidney injury because your kidney is really, really smart and is trying to maintain a normal GFR by dilating the afferent and constricting the efferent. If you just take an example of a hose pipe, right, you connect it to a tap, make a hole right in the middle of the hose pipe, and if you open the tap more, what's going to happen? More water is going to come out of the hole, right? That's what is happening in your kidney by dilating the afferent arteriole. More water or more blood is coming in. So you're maintaining a flow. And if you ask one of your friends to actually step on the pipe distal to the hole where you've made a hole, and if somebody steps on it, what's going to happen? Again, more water is going to come out of the hole. That's what is happening in your kidney when it constricts. The efferent arteriole is trying to maintain the pressure in this unit to maintain normal GFR, right? And this is why me and you, if you don't have any diabetes, if you don't have any hypertension, will maintain a normal GFR. Whereas if you have an 80-year-old who's got diabetes, hypertension, atherosclerotic disease, what's happening to their blood vessels? They are not as pliable as mine or yours, or what's going to happen? You can't dilate, you can't constrict. They go into acute kidney injury with minor amount of volume depletion, right? Very, very, very minor amount of volume depletion. So anytime you're volume depleted, this is what's happening in the kidney. This is being dilated, this is being constricted, right? So now you have a patient who is volume depleted because he's having diarrhea or gastroenteritis and he comes into the ER, is having some abdominal pain. What's the first thing they get? Toradol, ketorolac, right? Somebody is volume depleted. They're dependent on this vasodilatation. And what are you doing by giving NSAIDs? You're actually blocking the kidney's response to maintain a normal GFR. That's why even small doses of ibuprofen, Toradol, are going to put you into acute kidney injury because at this point of time, your kidney is dependent on this vasodilatation and NSAIDs are blocking this. This is why cyclosporin or radio contrast, right? That's why do you give recommendations that, anyone who's getting contrast should be volume repleted? Because if your volume down, you're dependent on this vasodilatation. And where does contrast act? Contrast actually constricts this. So that's why you gotta make sure that nobody is volume depleted before you give them a radio contrast. The other things which block this vasodilatation are cyclosporin, high calcium, and actually that's what happens in hepatorenal syndrome too. And that's why ACE inhibitors and ARBs are not recommended when you're volume depleted. They're beautiful drugs for chronic kidney disease, right? But when you're volume depleted, what are they going to do? They are going to block this efferent vasoconstriction, and what's going to happen? The pressure here is going to fall. You're going to go into AKI, right? Beautiful drugs in chronic kidney disease, not good when you're volume depleted. Make sense? Now, so the magic is happening in here and here. But what's happening right here? So I told you 3 systems get activated, right? We've already talked about sympathetic system. But the 2 other systems are what? Renin, angiotensin, aldosterone. So under the influence of angiotensin 2 and aldosterone, you reabsorb all the sodium possible. In your tubules, under the influence of angiotensin 2 and aldosterone, you're reabsorbing all the sodium possible because your kidney is smart. It doesn't want to lose salt and water. It wants to retain it, right? So that's why your urine sodium goes low, because you're reabsorbing it. Because angiotensin 2 and aldosterone are activated, and they want to reabsorb all the sodium possible. Along with sodium comes water, and along with water comes, wherever the water goes, that's where the urea goes. Urea just follows the water, right? So under the influence of angiotensin and aldosterone, this is being absorbed. Since this is being absorbed, water is being absorbed. Since water is being absorbed, urea is being absorbed. And actually, even more water is being absorbed under the influence of the third hormone, which we talked about. And what was that? ADH, right? So you are reabsorbing urea, you're reabsorbing water, you're reabsorbing sodium, right? So hopefully the next slide should be pretty easy now. So how do you differentiate pre-renal from some damage to the kidney, right? So the first thing is urine osmolality will be high in pre-renal. And why is that? What is urine osmolality? It is nothing but how concentrated your urine is, right? We actually ignore the dipstick. The specific gravity tells you the same thing, right? If the specific gravity on the urine dipstick is 1.030, it's a very concentrated urine. But again, if you don't want to rely on specific gravity, urine osmolality is going to be high in pre-renal. And why is that? Because under the influence of ADH, what are you doing? You're reabsorbing water. And if you're reabsorbing water, what's going to happen to the concentration of the urine? It's going to be that dark yellow, right? So that's urine osmolality is going to be very, very high. Whereas in ATN, even though the ADH could be high, it cannot act on the tubules. So what happens is whatever is being filtered through the glomerulus, and what is being filtered is plasma, right? What is the osmolality of plasma? Roughly 300. So 300 is being filtered. Nothing is happening in the tubules because tubules are not working, so it just comes out, right? So in ATN, the osmolality is going to be roughly close to plasma osmolality because you can't do anything to it because the tubules are damaged. Urine sodium is going to be low in pre-renal. Why? Because under the influence of angiotensin 2 and aldosterone, you're reabsorbing it. Whereas in ATN, even though the angiotensin 2 or aldosterone could be high, tubules are not working. You can't get it in, right? So your urine sodium is going to be high. A finer look or a more sophisticated way is to check a fractional excretion of sodium. They are not going to ask you to calculate it. They'll give you a value. So it will be low in pre-renal. It is going to be high in ATN. BUN to creatinine ratio might be high in pre-renal. Why is that? Because you are reabsorbing water, and along with water, what gets reabsorbed back into the bloodstream? Urea. So your blood urea nitrogen goes up. Can you reabsorb creatinine? No, that's why it's used as a marker of kidney function. That's why BUN to creatinine ratio goes up in pre-renal, right? Whereas in intrinsic ATN, can you reabsorb urea? If you can't reabsorb water, you can't reabsorb urea, so that's why the ratio is less than 20:1 or less than 10:1. Make sense? Now, this fractional excretion of sodium is less than 1, and I've also put, in bold letters, fractional excretion of urea of less than 35 in pre-renal. Where did we get this number? 35 is based on studies, so it's not an absolute number. But why is fractional excretion of urea less than 35? As I told you, what's happening in pre-renal? You're reabsorbing water, and along with water, what gets reabsorbed? Urea. So what happens to the urea in the ultrafiltrate? It becomes low. So if I checked, it's calculated exactly like fractional excretion of sodium, but you just change the numbers. They're not going to ask you to check it. They'll give you a number, and they'll ask you to interpret it. So if I checked somebody's fractional excretion of urea today, and it's 6, it seems it's very, very, very pre-renal. 2 days later, it is 15, still pre-renal. Next day is 25, it's still pre-renal, but what's happening is you are saying that things are transitioning. right? Even though it is still pre-renal, things are changing. So what I want to actually point out is, yes, we use less than 35 as pre-renal, more than 50 as, or more than 55 as damage to the kidney. It's a continuum, right? If somebody's fractional excretion of urea changes from 6 to 35, I know that this patient probably is transitioning into some tubular injury, right? Lower it is, higher the likelihood that this is pre-renal, okay? You don't have to worry about this. And of course, just forget about all these numbers. If you see muddy brown cast, it is ATN, right? You're seeing dead tubules. What proof do you want, right? Don't waste your time on calculate. It is ATN, right? If it's you're seeing it, make sense? Okay, the board loves to test you on when would you use fractional excretion of urea. So most of the time, fractional excretion of sodium is good enough. But again, if somebody is on diuretics, right? If somebody just took Lasix, of course, your fractional excretion of sodium is going to be high because you're blocking the sodium chloride potassium reabsorption in the ascending loop of Henle, right? So in those cases, I would go with fractional excretion of urea. Having said that, if somebody is on diuretics and their fractional excretion of sodium is still very low, it's very, very, very convincing that the patient has pre-renal. So if you're on diuretics and your fractional excretion of sodium is very low, it's pre-renal. But again, if it's high, you cannot say that it is not pre-renal. In those cases, what are you going to use? Fractional excretion of urea. And of course, I've already pointed out, this trumps sediment. If you see muddy brown granular cast, it trumps everything. It is ATN, right? This is from an iPhone. So you can actually take, pictures on the microscope from your iPhone very easily. So this is, again, a close-up picture, but this is, if you see this, you know that the patient has ATN. But very shortly, I'm going to tell you ATN is not a diagnosis, right? You still got to figure out what is causing an ATN. And ATN is very, very, very easy. There's only two things which cause ATN, broadly. One is you are pre-renal. I don't fix it. You're pre-renal. You're pre-renal. What is your kidney doing? It's dilating, it's afferent, it's constricting, it's efferent, it's pulling all the sodium and water. You're pre-renal right now, but I'm still not fixing it. It's no fixing, no. And ultimately what happens? All this, hemodynamic, protection measures fail, and you start going into ATN. So it's pre-renal, 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 pre-renal. ATN is what we call as ischemic ATN. It can happen very suddenly too. It doesn't have to be pre-renal. It could be quick pre-renal. And again, if the hyperperfusion is so much that you can't actually protect your kidney even through all your measures which are protective inside the kidney, you'll go into it quickly. The other one is nephrotoxic, and very, 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 very simple again to think about it. So it's toxic, right? Where are the toxins coming from? Most of the time, the toxins are coming from the physicians, right? It's what we call as exogenous. We give them toxins. So you got to actually look at the drug list. What did the patient get? Go back and look at, when was the last time a CT was done? Was there a contrast agent? Look at the, you don't have to know all the drugs. Yes, these are some of the classical drugs. Did the patient actually get any sucrose, mannitol, or dextran? Actually, dextran now has a black box warning, so hopefully nobody is using it because it can actually give you what we call as osmotic nephropathy. All these agents can actually get into the proximal tubules and cause damage to the proximal tubules pretty fast, especially if you have underlying kidney disease. So you got to look at what is the patient getting. So that is exogenous. And then there are only two endogenous toxins, right? Myoglobin and hemoglobin, right? Myoglobin comes from the muscle, right? The biggest one would be, it's a rhabdomyolysis, so it can be statins, cocaine, trauma. And one of the things which board loves to test you on is electrolytes. Low electrolytes can give you rhabdo too, right? And the two electrolytes which can actually cause muscle injury are if you have very low phosphorus or low potassium. And how they test you on this is they'll give you a diagnosis, they'll make it so clear that the patient has rhabdo. But they're going to ask you what is the cause of the rhabdo. And what you're going to see on the labs is what? A normal potassium. So when you are having rhabdo and the muscles are breaking down, what should you have? A very high potassium, right? It should be 6, 5.5, 6.5 because muscle is releasing potassium. But if your potassium level is 3.5 and you have rhabdo, it tells you a story that the patient's potassium when the rhabdo started was probably 2 or 2.1. It's the same with phosphorus. When you have rhabdo, you should have high potassium and high phosphorus from cell breakdown. But if you see low normal levels, they're trying to tell you that probably the rhabdo is from either low phosphorus or low potassium. Okay, so they really love to test you on this next thing, which I'm calling as a portal, right? Because the diagnosis is done. They want you to recognize that if you have a dipstick which is positive for blood, but you don't see any RBCs on your urine microscopy, right? You have a dipstick which is turning, 3+ blood, and when I see 3+ blood on the dipstick, I am, when I'm looking under the microscope, I'm hoping to see like too numerous to count RBCs. But when I'm looking under the microscope, I'm seeing 1 to 2 RBCs. Doesn't make sense. Diagnosis is actually made. Either it's myoglobin or hemoglobin. So you got to look at the risk factors. For myoglobin, you'll check a CPK and an aldolase. For hemoglobin, it's mostly intravascular hemolysis. It has to be intravascular. That means the red blood cells are breaking down inside the blood vessels, right? So what are you going to do? Check a peripheral blood smear. You'll see cystocytes maybe on there. High LDH because RBCs are breaking down. Haptoglobin will be low, and indirect bili is going to be high. What do you do with pigments? You give them aggressive hydration with isotonic saline. For rhabdo, your goal should be urine output, right? Your urine output, you should maintain a urine output of about 250 cc's per hour, right? And the basic recommendation for rhabdo is you should at least give 3 to 4 liters of normal saline as fast as possible because each limb, right, each thigh can actually third space about 1.5 to 2 liters very easily. Right? You got to give a challenge of 3 to 4 liters, but please, after 4 liters, if there's urine output is not improving and the kidney function is worsening, stop, right? Because now probably the injury has already happened, and what you're going to do is actually cause pulmonary edema and respiratory distress. So you got to give a challenge, but you got to know when you got to stop because the injury has already happened. But again, if the urine output improves, you got to maintain a urine output of about 250 cc's per hour until at least the CK is less than 10,000 or 5,000. There's some, animal data related to urinary alkalinization that you need to get the pH above 6.5. The human data is very, very, very weak, right? And it is very hard to maintain a urine pH of more than 6.5 in rhabdo. So it's this, I would say this is just expert recommendation that you can actually try and give these patients some bicarb-containing solution, but you're not going to be tested on it because it's not a very strong recommendation based on high-quality evidence. So we've covered ATN. You got to know acute interstitial nephritis. So the classical thing which we teach you, starting from med school is this classic triad: fever, rash, and eosinophilia, right? You have a drug rash, this maculopapular rash. you have slight fever, and when you do a CBC with differential, you should see minor amount of eosinophilia, right? Eosinophil counts of about 450, 500, 600, slightly elevated, fever, rash, eosinophilia. But when you actually look at the data, this classical triad is only present in 30% of patients. So what the board wants you to recognize is that if you have WBCs or WBC cast in the urine without any evidence of infection, you should be thinking about what? Interstitial nephritis. If you see WBCs in the urine and there's no infection, you've done urine cultures, there's nothing, you should be thinking about interstitial nephritis. The number one cause is drugs, right? It used to be NSAIDs and antibiotics, and now PPIs are right there. Proton pump inhibitors are right up there because we distribute it like candy, right? Somebody just has to say something related to, not feel, and you get a PPI, right? So that's becoming one of the major causes for interstitial nephritis. And somehow I have no idea, but the boards also loves Sjogren and sarcoidosis. Both of them can cause interstitial nephritis, SS. And you'll see this is kind of a recurrent theme. They like Sjogren and sarcoidosis overall in the boards. So if you don't have any idea, just pick one of those, all right? But they really like Sjogren and sarcoidosis. So the number one cause is drugs. And for clinical practice, I would just recommend not to order eosinophil stain in the urine because I've seen, there's no WBCs in the urine, and some of my residents are ordering urine eosinophil stains. I have to remind them that EO is still a WBC. If there's no WBC, you're not going to somehow magically find, But anyways, that's clinical. So PPI-associated acute interstitial nephritis, eosinophilia is not very common with PPI. So you are not going to get this classical triad, right? So if you do a CBC with differential, and you probably are not going to see eosinophilia. So your biggest clue is still going to be, slowly worsening kidney function, and you might have WBCs in the urine without any evidence of infection. Acute kidney injury after cardiac cath. The two biggest differentials are, one, contrast nephropathy, which I think is a little overrated. Most of the time, we admit somebody, we give them contrast, we check their serum creatinine the next day, it's fine, you discharge them. But again, if you look at it, most of the AKI develops in 48 to 72 hours, actually. So by the time there's chance of worsening creatinine, you've already checked their creatinine prior to that and send them home, right? So you're going to actually miss it. But the question is, what are you going to do with it too, right? And most of it, again, if you look at the data, is not very consequential. What do you do about it? The only bottom line would be what the board is going to test you is hydration. There was a study which was published in Lancet too about this sodium bicarbonate trial. Everyone started giving, rather than normal saline, bicarbonate containing solution to these patients. But if you look at this study closely, if there was one more negative patient, this would have been a totally negative study, but they stopped it early. One more negative would have actually totally taken the bet, but they reached a significance and it was stopped. After that, multiple studies have shown that there's no difference between normal saline and bicarbonate containing solution. So bottom line is hydration with normal saline. If you want to feel good, you can give an acetylcysteine, but the evidence is actually, I would say there's no evidence at all. There's maybe slight signal for high dose Mucomist 1200 milligram POBID, but if you look at the recent meta-analysis, it's probably we are treating ourselves and we feel better rather than making any differences with the patient outcomes. But it's cheap, it's harmless if you want to give it, sure, but the evidence is not there. The other big thing is AKI after, if you have a cardiac cath or a procedure which involves actually accessing arterial circulation, the classical thing they love to test you on is atherembolic disease. So what is the course of things in AKI after contrast is you get contrast, you have slight worsening in kidney function in 48 hours to maybe sometimes 72 hours, and then kidney function starts improving. Whereas in atherembolic disease, the kidney function doesn't improve, right? So you have a baseline creatinine of, let's say, 1.1. After 5 days, it's 1.4. It'll remain at 1.4 for some time. 15 days later, it's 1.7, 1.8. So it's a stepwise worsening of your serum creatinine. If you look at this, these are, again, you can, if you do a retinal exam, you can see cholesterol or atherembolic deposits in the vessels. One other thing is you can actually see this lacy purplish livedo reticularis kind of a rash in the lower extremities. And you can, again, if you remove the socks, you might see, again, peripheral emboli as well. It's very interesting that within 24 to 48 hours of actually an atherembolic event, you'll again see eosinophilia. So eosinophilia is somehow present for 24 to 72 hours after this, a shower of emboli actually goes through. So sometimes one clue is eosinophilia, and about 2 to 3 days after this event, you can actually see low complements as well. But by the time it gets recognized, the complements have normalized. And the other clue could be sometimes high amylase related to atherembolic events. What can you do about it? This is, again, surprisingly paradoxical. You need, again, if you can stop anticoagulation, you stop anticoagulation. So somehow continuing anticoagulation is associated with worsening atherembolic disease. Of course, I'm not going to stop Coumadin or heparin if somebody has a CHA2DS2-VASc score of 3, 4, 5 when they actually need it. So what I'm saying is, if the indication for anticoagulation is something frivolous, you don't need it, stop it. And again, there's some evidence that statins may stabilize some of these plaques and stop atherembolic events, but otherwise this is very supportive kind of a treatment, and wait and watch rather than doing something dramatic. A 51-year-old Caucasian female with acute kidney injury, history of hypertension, hypercholesterolemia, and type 2 diabetes mellitus. Medications are lisinopril, hydrochlorothiazide, glipizide. 2 weeks prior, admitted to another hospital because of weakness. Lab test 2 weeks earlier showed a serum creatinine of 1.4. Hemoglobin was 10.1. And during that hospitalization, she underwent a colonoscopy. She's now presenting with a serum creatinine of 6.3, like 2 weeks later. Potassium is 5.3 and phosphorus is 11.2. What's the etiology of her AKI? Great. So the answer is acute phosphate nephropathy, and I just wanted to bring it out because this is going to be fair game for the boards, because over the last 7 to 8 years, we are recognizing a lot of these undiagnosed, I don't know why this patient went into AKI or what happened. We are recognizing that it could be acute phosphate nephropathy, and I've actually I've published a few case reports, and I've actually seen about 5 to 6 patients over the last 2 years. So what is it? So what happens is Again, in this case, what did we see? That the patient was admitted 2 weeks back, had a colonoscopy. The boards won't give you what they got for colonoscopy, right? And sometimes what they'll tell you is that the patient was constipated for some time and was admitted. But most of the time, does anyone know whether somebody got a Fleet's enema during hospitalization? Half of the time it's that PRN order. If you have constipation, put Fleet's enema. And sometimes, we had to actually dig in so many times to figure out whether somebody got something or what they got. And now Fleet's enema actually has a black box warning, right? And you shouldn't actually be using it in anyone who's more than 50 or there's any chronic kidney disease. So if you give a high dose of phosphate containing solution to somebody, that phosphate gets absorbed, combines with calcium, and actually has calcium phosphate deposition in the tubules, and you will have acute kidney injury. It's very hard to diagnose because if it's all historical based on what they got. The clues are very high phosphorus levels. So if you saw this patient, what was the phosphorus level on that patient? 11.4. That is way out of proportion to acute kidney injury. Somebody got a huge load of phosphorus. The other clue would be a bland urine. So if you look at the urine, it's very bland in these folks. You won't find much. So the only factor would be recent exposure to an oral sodium phosphate ball preparation or Fleet's enema. So anyone with my recommendation would be anyone more than 50 or anyone who's got chronic kidney disease and diabetes, don't even use phosphate-containing oral solutions or Fleets. So again, this is the clue which is going to get you the question right for the boards. I bet, I think it's very fair game, and there's a very high likelihood because they want all the internists to know this, that they are going to check you on just knowing this concept. One other thing is you need to know about abdominal compartment syndrome. A lot of the patients which we thought about 10, 15 years back were all hepatorenal syndromes. About 25 to 30% of them, when you look back, were abdominal compartment syndromes, right? So what is abdominal compartment syndrome? My abdominal pressure right now, is about 4 to 7, right? That's the normal compartment pressure. And if you're obese or if you are in positive pressure ventilation, it could be 6 to 12. Anything more than 12 is intra-abdominal hypertension. 12 to 16 is grade 1, 16 to 20 is grade 2. Anything more than 20 with organ dysfunction, and the most common organ dysfunction is acute kidney injury, is what we call as abdominal compartment syndrome. So pressure more than 20 and you have organ dysfunction, right? So if somebody is coming in with massive ascites or has necrotizing pancreatitis or has trauma and you go in and you're seeing this very tense belly, something should cross your mind that could this patient have abdominal compartment syndrome? Because when you do their urine indices, right, like if you check a urine sodium and fractional excretion of sodium, what is it going to look like? It's going to look like pre-renal, right? Because the pressure is so high, it is compressing the veins, renal vein too. It's not compressing your renal artery because you can't compress your renal artery, right? Even when you're hypotensive, your MAPs are what? 55, 60, 65. So your abdominal compartment, the pressure should be 75 or 80. Your belly is going to explode with that kind of a pressure to compress the artery. So it's the venous part. So it looks exactly like pre-renal. So if you do a fractional excretion of sodium and it's less than 1, what are you going to do? You're going to give them more fluids. It's already tight. You're going to actually worsen things, right? So what you have to do is, and in my hospital too, you got to sell your soul to do it on the floors. But it's a very easy thing to do. All you have to do is put in a Foley catheter, put 50 or 25 cc's of normal saline and attach a transducer to it, and it'll give you the pressure, right? It's a very easy test to do. It actually can be done in less than 5 minutes. Putting a Foley, attaching a transducer after you put in 25 cc's of normal saline into the bladder, it'll give you the bladder pressure. But sometimes just because of policies, I have to just shift the patient to the ICU to check it. Doesn't make sense, right? So please, 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 if you see a tense belly, acute kidney injury, and the urinary indices are pre-renal, think about abdominal compartment syndrome. Do what? Do abdominal pressures. Very easy to do. Your nurses, anyone can actually do it within 5 to 10 minutes. And of course, the treatment is again, if you have necrotizing pancreatitis or trauma, it's decompressive laparotomy. You just open the belly up and keep it open. If it's massive ascites, it's large volume paracentesis, right? Decrease the pressure, and sometimes as soon as you decrease the pressure, you'll see the urine volume increases and the serum creatinine starts coming down. And then, of course, monitor the abdominal pressures regularly to make sure that you're keeping it less than 20 or as low as possible. So some abnormal urine analysis, pearls, they love to test you on what I already told you, positive dipstick, but no RBCs on the microscopy. You should be thinking about either hemoglobin or myoglobin. If you see RBC cast or dysmorphic RBCs pretty soon, I'm going to tell you, you got to be thinking about glomerulonephritis, glomerulonephritis, glomerulonephritis. We haven't gotten there, but we'll be talking about it. If you have WBCs without any evidence of infection, for all practical purposes in US, it should be interstitial nephritis. But again, if somebody is from Southeast Asia or in areas where tuberculosis is prevalent, at least that thought should cross your mind, right? Because that's what renal TB can actually give you, sterile pyuria too. Eosinophils in the urine, not present all the time, but actually should make you think about drug-induced interstitial nephritis. And as I mentioned, it can also be seen with athrombotic disease, right? You have a cardiac cath, and 3 days later, you can actually have CBC with showing eosinophilia and some eosinophils in the urine as well, because that's what cholesterol does. It activates eosinophils. A 77-year-old gentleman presents with nausea, vomiting, and general malaise. 10 cc's urine output in the last 2 days, past medical history as is given here. Exam, pale and stuporous, blood pressure is high, loud carotid bruise, faint systolic ejection murmur, clear lungs. I haven't given you much. Potassium of 5.4, creatinine is 6.4, BUN is 165. Urine analysis is very bland. There's nothing. Which of the following is the next best step in the management? Awesome. I don't even have to. Again, the only point here I want you to know, the first thing anyone should do when you're actually having a patient with AKI is rule out obstruction. You don't want to be talking to the whole team, talking about urinary indices, fractional excretion, and somebody comes in, puts in a Foley, and 2 liters of urine comes out. It's pretty embarrassing when that happens. Okay. Quickly moving on to, again, very high yield topic for the boards, less than 10% in your clinical environment, but very high yield for boards, is glomerular diseases. Just a quick overview of proteinuria. Normal 24-hour urine protein is less than 150 milligrams per day. Most now we are very rarely doing 24-hour urine proteins because what we've realized is that a spot urine protein to creatinine ratio is as good as 24-hour urine protein, because I don't want very accurate results, right? 512 or 513. As long as I have an idea of how much, an estimate of the protein, that is good enough. Probably 10 years back, we were sending everyone with those brown bags and then store your, urine for 24 hours in your refrigerator, and then you spill it in your, you're scarred for life. And it's not even needed. So all you need is somebody comes in, somebody's in your office, do a random urine protein, do a random urine creatinine, divide it, and you have your number, right? So if your random urine protein is 200 milligrams and your random urine creatinine is 50, 200 divided by 50 is 4, and this number 4 is roughly in grams the protein this patient is excreting. So 4 grams in 24 hours or 4 grams a day, right? So all you have to do is random protein to random creatinine. And in me and you, the ratio should be less than 0.2. Most of the tubulointerstitial diseases will have minor amount of proteinuria, 0.5, 0.6, whereas glomerular diseases have a huge range. It could be 0.5 to nephrotic range proteinuria, which is more than 3.5 grams, which we're going to be talking about. So for board's purposes, I'm going to go back to this is exactly how the board is going to actually test you on these things. So the first thing which you got to do is if they're giving you a patient with proteinuria or hematuria, you got to divide them into what syndrome this patient has. That's your diagnostic approach. And nephrotic and nephritic syndromes are not diagnoses, but they help you in building a differential diagnosis. So the first approach is, does this patient have nephrotic syndrome or nephritic syndrome? And the main feature of nephrotic syndrome is what? Proteinuria, proteinuria, proteinuria. And how much proteinuria? Quite a bit, more than 3.5 grams. Whereas the major feature of nephritic syndrome is hematuria. And how do I know that this hematuria is coming from the glomerulus, which I showed you? The 2 pointers, if they mention in their urine analysis, they will. The patient had dysmorphic RBCs or RBC cast. They are telling you that it is nephritic syndrome. Like they've already told you if they've mentioned either dysmorphic RBCs or RBC cast, they've told you that it's nephritic syndrome, right? Of course, you're going to have some amount of proteinuria as well, but this is what you need for nephritic. Make sense? Huge amount of proteinuria, more than 3.5 for nephrotic, hematuria for nephritic, right? And so if you are in your clinic and you did a dipstick, you'll see 3+ blood, a little bit of protein, right? A combination of hematuria and proteinuria should start making you think about nephritic syndrome because there's hematuria. And if you look under the microscope, what are you going to see? Dysmorphic RBCs or RBC cast, right? They'll tell you dysmorphic RBCs most of the time, right? So that tells you that the blood is coming from the glomerulus, small amount of proteinuria. Of course, it's nephritic syndrome which causes AKI most commonly, not nephrotic syndrome. Nephritic syndrome is the most commonly associated with AKI. So you'll have elevated BUN and creatinine, and since the glomerulus is not working properly, you're not getting rid of fluid, normally you'll have hypertension and edema. So again, this is RBC cast. This is again from an iPhone. This is a perfectly round RBC, so this is dysmorphic RBCs. You'll see some blebs on the RBCs, which are very common, which makes them dysmorphic. And I know that these are coming from the glomerulus. There's inflammation going on in the glomerular capillaries, minor amount of protein, and this we've already talked about. Another example of RBC cast, and you see this bleb. The blebs tell you that, sometimes people call it Mickey Mouse too. If there's another bleb here, that would tell you that it is coming from the glomerulus and it is nephritic syndrome. So now this is the key part for boards. So you've figured out that it is nephritic syndrome because the patient has proteinuria and hematuria, and the hematuria has dysmorphic RBCs or RBC cast, right? You figured out that this is nephritic syndrome. They're not going to stop there. So the next thing what you want to look at is complements, 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 right? And what are you going to check for complement? C3, C4, and sometimes you can do the whole complement as a CH50. But C3 and C4 is what you're going to check. And if the C3, C4 comes back low, you got to remember, so there's no way for me to actually give you any other way of memorizing it other than you got to memorize it, because that is the key. So if your complements come back low, your differential diagnosis is post-infectious glomerulonephritis, which most commonly classically happens after strep, but now we know it can happen after staph and other infections as well. Infective endocarditis, that's the biggest mimicker of glomerulonephritis, biggest mimicker. So I always check. If the complements come back low, I always check blood cultures, do a good heart exam, and if there's any doubt, at least do a transthoracic echo. Lupus, cryoglobulinemia, and MPGN, the dreaded MPGN. I'm just going to tell you what you really need to know for the boards for MPGN, right? But you got to remember these 5 things if your complements are low, because that is going to depend on how you answer the questions and actually clinically as well. But if the complements are normal, 2 things need to be checked: ANCA and anti-GBM. If the ANCA is positive, there are 4 diagnoses. You treat most of them exactly the same, but they have got some therapeutic and prognostic implications. So if the ANCA comes back positive, it could be either GPA, which was called Wegener's previously, microscopic polyangiitis, eGPA, which was called Shirk-Strauss previously, and all these 3 things, GPA, microscopic, and eGPA, are vasculitis, right? Vasculitis means multiple systems are involved. Whereas if the effect is only in the kidney and ANCA is positive, we call it renal limited ANCA, right? It's just a matter of semantics, as I'll tell you later on. Whereas if anti-GBM comes back positive, we call it anti-GBM kidney disease, and 2 weeks later, if this patient has alveolar hemorrhage, we start calling it good pastures. We treat everything the same, so it's again a matter of semantics, right? So if your complements are normal, what could it be? Anti-GBM or ANCA? Am I missing something? IgA. So IgA, so this is a key point. IgA nephropathy is very common. It's an immune complex disorder, but with normal complements, because the complement activation just happens in the kidney. It's not good enough to decrease the complement levels in the serum. So the serum complement levels are going to be normal in IgA nephropathy. Henoch-Schönlein is nothing but IgA vasculitis, like along with kidney, other organs involved, and I'll show you what you need to know about that. But you got to remember, IgA, yes, it's an immune complex disease, but it has normal serum complements, right? That's why I've put it over immune complex, but this will have normal complements. So which 3 have normal complements? ANCA, anti-GBM, and IgA. And these 5 have low complements. You got to remember that. Okay, now just key points about what they might test. So acute post-infectious GN, low complements or normal complements? Low complements, right? Usually occurs in children. Post-strep GN is kind of most common cause of post-infectious, but it can happen after staph too. And after strep, what is the classical scenario? Either you'll have strep pharyngitis or impetigo, a dermatomal, hand infection of strep. Classical picture is going to be you have either this pharyngitis or skin infection. 7 to 10 days later, you come in with cola-colored urine, right? They'll most of the time they like to use these classical terms too. Cola-colored urine, mostly they use it with post-infectious GN. Usually after how much time? You have a upper respiratory tract infection, 10 days later, they're coming in with hematuria, right? And after skin infection, it can actually be 30 days, right? So you need to know, did you have a strep skin infection or some kind of an impetigo kind of an infection in the last 1 month or so? The classical thing I've already told you is preceded by this. It will be associated with what? Decreased complement levels, especially C3. And this could be giving you a clue, ACE or titer, right? Again, it's not very sensitive or specific, but it might help you tailoring your diagnosis. Now I want to contrast it with IgA nephropathy. This most commonly also, it's a very, very, very common cause of glomerulonephritis. Most of the time, it is also preceded by upper respiratory flu-like infection. So most of the time, it's confused between post-infectious and IgA. You're confused, like, is it post-infectious or is it IgA? And that's what board is, the boards are going to try and confuse you too. But the classical thing here is what? Normal complement levels and the timing. I have an upper respiratory tract infection right now. 2 days later, I come in with gross hematuria. I'm like, it's just very scary. A 22-year-old is coming in with bloody urine. I'm like, I'm peeing blood. But you got to realize all you need is about 0.5 cc's of blood to make your urine look like it's blood. Right? Very little blood is needed to make it look like it's just, they're going to tell you it's all blood is coming out. And the infection happened when? 2 days later, not 7 to 10 days later or 2 weeks back. So very close to the infection. So that's why it's called synpharyngitic. That means very close to the infection rather than post-infectious. And the classical thing is going to be complements are normal and very close to the infection. And that is what separates it from post-infectious, right? And this, they love to test you on is Henoch-Schönlein purpura is nothing but IgA vasculitis. So you'll have exactly the same picture, but in addition, you'll have palpable purpura, right? Generally in the buttocks, right? They'll have palpable purpura, so that's vasculitis happening. And there's arthralgia, so multiple joints being painful. Generally, arthritis is less common. Abdominal pain because you've got vasculitis in the blood vessels of the mesentery as well, and exactly the same picture for renal involvement, that you'll have hematuria and proteinuria with normal complements, right? So Henoch-Schönlein is IgA vasculitis. Of course, IgA nephropathy happening in the kidney, but in addition, joint involvement, skin involvement, and abdominal pain. Make sense? Complements are normal or low here? Normal. That is the key. Cryoglobulinic glomerulonephritis. So there are 3 types of cryoglobulins. What are cryoglobulins? Name tells you the answer, right? These are proteins which precipitate in cold temperatures, right? Most of the time, how do they present? I should even, maybe I should put this as, rather than Raynaud's phenomena, it should be pseudo-Raynaud's, because it's actually not Raynaud's. It looks like Raynaud's, right? Patients are going to actually tell you that, their nose or their fingertips actually change colors, and you're like, oh, it's a Raynaud's, but it's not Raynaud's, it's pseudo-Raynaud's, because what's happening is cryos, these abnormal proteins, are precipitating in the tips because the temperature here is lower, right? There are 3 types. The first one is associated with lymphoproliferative disorders like Waldenstrom's or CLL. The third type is associated with connective tissue disorders like lupus. But the most common, which they are going to test you on, is type 2, which is associated with hepatitis C. It can also be associated with hepatitis B, but hepatitis C is the most common. So the classical thing, which is very, very, very interesting, is, of course, they're going to give you risk factors for hepatitis C. It also presents with purpuric rash, right? Pseudo-Raynaud's phenomena, because that proteins are precipitating in the cold temperature, and this is the key. There's no other disease which has this classical C4. It's like pattern recognition. C4 is going to be very low. C3 is going to be slightly lower normal. That, as soon as you see it, it should be a pattern recognition that, I got to be thinking about cryoglobulinemia, right? And boards wants you to pick that pattern recognition part too. But they're not going to only give you this clue. There'll be 3 or 4. You got to miss 3 or 4 clues to miss this diagnosis. Make sense? And I'll bring it together. Third one is lupus. Low complements or normal complements? Low complements, right? So what they want you to know is, of course, they'll give you multiple features of lupus, right? Mouth sores, alopecia, butterfly rash, lymphadenopathy, pleuritis, serositis, arthralgias, low counts, you name the thing, and they'll give you some kind of combination of these features. If they give you this with nasolabial sparing, of course, it's very clear. But what they want you to know is, again, yes, the most worrisome type of kidney involvement with lupus is type 4 lupus nephritis. You don't need to know more than that. It is an emergency. It needs to be treated very, very fast. If you're worried about lupus, what do? You start with a very sensitive test, ANA, right? ANA is very sensitive. And if the sensitive test is positive, then you do a specific test, right? What are the specific tests? Double-stranded DNA or anti-Smith antibody. And of course, they are associated with active lupus is associated with decreased complement levels. All they also want you to know is treatment. Induction could be either cyclophosphamide or MMF, mycophenolate, along with steroids. If probably they're not going to give you both these choices because both of them actually work, and we have more data with cyclophosphamide. But over the last 8 years, MMF is becoming the treatment of choice for most because of the side effects associated with cyclophosphamide. And maintenance therapy, again, is MMF2, mycophenolate. Right? They want you to know, they don't want you to know a lot of details, but they do want you to know that MMF and steroids are the way to go with lupus nephritis. Nothing more than that. MPGN, again, the most dreaded thing, probably from the med school days too. All you need to remember is it is associated with Hep B and Hep C. So they'll give you clues for Hep B and Hep C, like elevated liver enzymes, maybe some risk factors for Hep C. This is the only disease which can present with both nephrotic and nephritic syndrome, right? At least for both purposes. So what they'll give you is maybe if there's 4 grams of protein and there is hematuria. So the protein level is nephrotic range proteinuria and there's hematuria. Start thinking about MPGN, right? Both nephrotic and nephritic combined. Low C3 levels in majority of the patients. There's a new entity called C3 glomerulopathy. I don't think they are going to be testing you on that. So I, again, want you to remind that glomerular diseases which are associated with low complement levels, you've got to remember it because that is going to be the key to answering most of the questions what are going to be on your boards. Got to remember what causes low complements. Now, normal complements are ANCA and anti-GBM. As I told you, if your ANCA is positive, it could be either GPA, which was called Wegener's, but then they realized that he had some Nazi associations. He did get ACCP recognition, which was rescinded in 2007 when they came to know about all this prior history. It's an interesting read. But, I just want to point out poor Schurk-Strauss, they were good pathologists, no bad history since they were changing the name here. It was collateral damage here. So GPA, or previously Wegener's, what is it? All you need to remember is, again, pattern recognition, both upper respiratory tract and lower respiratory tract involvement, right? Upper respiratory tract involvement can be in the form of, you name the thing, mastoiditis, sinusitis, epistaxis, tracheobronchitis, laryngitis, you name the thing and it can cause it in the upper respiratory, and the most common thing they try and present is sinusitis, which is being treated by multiple physicians with multiple antibiotics, not getting better. Lower respiratory tract involvement, again, can be, you name the thing. Infiltrates, looks like pneumonia, fleeting infiltrates, cavitary lesions, and the most dreaded one is what? Diffuse alveolar hemorrhage, right? The classical pattern on immunofluorescence in GPA is C ANCA, cytoplasmic ANCA, and if you check the ELISA, the antibody is against proteinase 3. So you should never order ANCA alone. ANCA should always be ordered with reflex ELISAs. ELISAs do what? They check what the antibody is against. So if you just do ANCA, they'll give you, C ANCA is positive. But C ANCA is positive doesn't tell you anything till I know what the antibody is against, right? Whereas in microscopic polyangiitis, the ANCA is perinuclear ANCA on immunofluorescence, but if you do the ELISA, the antibody is against myeloperoxidase. What if you have ANCA, and you do ELISAs, and the ELISAs don't show any antibodies against proteinase 3 or MPO? What do we call it? Again, I'm going tangential. That's atypical ANCA, right? This is what you see with chronic active hepatitis, sometimes with rheumatoid arthritis, sometimes you can actually see it with other autoimmune diseases too, or inflammatory bowel diseases like ulcerative colitis or Crohn's, right? Where you have ANCA positivity, but the ELISAs don't pick up antibodies against proteinase 3 or MPO. So we talked about GPA. Microscopic polyangiitis, again, can give you diffuse alveolar hemorrhage, but the most common thing they love to actually test you on is, let's say I come to your clinic with left wrist drop today, and 10 days later I come, not 10 days, let's say 2 months later, I come to your clinic with a right foot drop. So now I've got two peripheral nerves being involved in two different distribution. As soon as you see that, that's what is called mononeuritis multiplex, right? Two peripheral nerves being involved in two different distributions should make you think about vasculitis, right? Because what's happening is the vasa nervorums, the small blood vessels which supply the nerves, are involved, and it is causing injury, axonal injury, right? So that is the classical thing. Of course, it can also give you palpable, the same kind of a rash, which I showed you for henoxal and purpura or cryoglobulins. It can look exactly like that. And the antibody is against myeloperoxidase. This is very easy. EGPA is very easy, right? They won't give you asthma. They'll tell you that this patient has been using, his or her mom's inhaler. Of course, they're telling you that there's some bronchoreactive disease, right? They won't tell you straight away that it's asthma, but they'll give you enough clues that there's evidence of bronchoreactive disease. And then you do a CBC with differential and, impressive eosinophilia. Eosinophilia is not going to be what you see with interstitial nephritis, 450, 500. It's going to be 3,000, 4,000, 5,000, 6,000. Very impressive eosinophilia. Very, very, very easy, just based on pattern recognition. Make sense? Okay. How to remember all this? Look for clues in history and lab results. Place the case in broad category like nephrotic syndrome or nephritic syndrome. Narrow the differential based on complement levels. If you have a patient with kidney involvement and lung involvement, or use exactly the same chart. Exactly the same chart which I gave you for complements, checking the complement first, ANCA, anti-GBM, and IgA, because it's exactly how you approach the differential diagnosis. And actually, the same goes with the renal dermal syndromes, too. If you have kidney and skin involvement with palpable purpura, exactly the same chart should give you the right answers. A 19-year-old comes in with tea-colored urine for 1 day, history of rhinorrhea and cough for 2 days. Blood pressure is 138/92. Normal exam. Too numerous to count RBCs, 2 plus protein. ASO titer is positive, and C3, C4 are normal. Creatinine is normal. Which of the following is the most likely diagnosis? Great. So ASO titer was kind of a little confusing thing, so just remember the complements were normal here. It was very close to the infection as well. So the main thing would be, you could have just ruled out just based on complements, right? The complements were normal. All these four have low, if you didn't even know what was going on, just based on complements, you could have actually figured out what the right answer was. So the main feature, which we already talked about, nephritic syndrome was dysmorphic RBCs and RBC cast. The main feature for nephrotic syndrome is what? Proteinuria. So what are you going to see in the clinic? That the patient will have 4+ 3+ protein on the dipstick. When you check a urine protein to creatinine ratio, it's going to be more than 3.5 grams. But what is nephrotic syndrome? You are losing a lot of protein in the urine, And what is the protein which you're losing? You're losing albumin. So what's going to happen to your albumin? It's going to be low. So you have hypoalbuminemia. Where is the albumin made? It's made in the liver, right? What does the liver do? It actually revs up the production of albumin by about 30 to 35 times. So you're making a lot of albumin, but more albumin the liver makes, the more it is being lost. So the liver can't keep up with it. So you still become hypoalbuminemic. But since albumin is the most important osmotic protein, your liver starts making something else which is osmotic. And what does it make? It starts making extra lipid because it can't keep up with the albumin. So what happens with lipids? Your lipids go up. Some of the lipids actually spill in the urine, and that's what you see as lipid droplets or this Maltese cross under polarized light. That is what they're telling you. If they show you lipids in the urine, it's either nephrotic syndrome or genetic hyperlipidemias, right? Those they're not going to test you on. And since albumin is low, what are you going to have? Edema. So nephrotic syndrome, we already talked about huge amount of protein loss, more than 3.5. The major protein is albumin. Albumin goes low. Since albumin is low, you'll have edema, but now the liver can't make albumin. It starts making lipid. You become hyperlipidemic. Some of the lipid spills in the urine is lipiduria, and that's what you see. Along with albumin, there are also some other proteins which are being lost, including antithrombin and plasminogen. So what happens is, because of antithrombin loss, these patients are hypercoagulable too. So these patients are at high risk of thrombosis. This is they love to test you on this too, the high risk of thrombosis. Again, this is going to take you back to the med school days too. So if you have nephrotic syndrome, these four things should come to your mind, right? Minimal change disease, membranous, FSGS, and again, MPGN, which we've already covered, right? Because it can present with both nephritic and nephrotic. But how do you diagnose these things? All of them present with nephrotic syndrome. So here the board wants you to be a betting person. They want you to bet. They're not going to give you a biopsy result. They want you to bet based on epidemiology. So what do you need to know about minimal change disease? That if a young adult or a kid actually presents, like an 18-year-old or a 20-year-old comes in with nephrotic syndrome, what should you be thinking about? Minimal change disease. Actually, pediatricians don't even biopsy for the first time. They start them on steroids thinking that it is minimal change. If they don't respond, that's when they biopsy these patients. The other thing you need to know is it's very responsive to steroids, but it is also associated with NSAIDs and Hodgkin's disease. So if you have huge honking lymph nodes and you have minimal, if you have a 20-year-old coming in with nephrotic syndrome, lymphadenopathy, think about minimal change. NSAIDs, Hodgkin's, that's all you remember, and a young adult coming in with nephrotic syndrome. FSGS, if you have an African-American gentleman or a lady coming in with nephrotic syndrome, think about FSGS, and the major reason is genetic. We are actually unraveling this mystery. A lot of these patients have genetic mutations. One of the big ones is APOL1, but there are other which are being uncovered. So the major reason is genetics. There are some different types of FSGS. One is collapsing FSGS, which actually presents with acute kidney injury, which is associated with HIV. We are not seeing it very commonly because of highly active antiretroviral therapy. And the other association is if you are morbidly obese, you can actually have scarring in your kidney and you can have FSGS. But just remember, the main thing would be if you have a patient who's an African American, because of genetic reasons, the higher probability is of FSGS and nephrotic syndrome in them. Membranous, this would be your betting if you have a patient who's a Caucasian adult, and there are some risk factors for cancer. They'll give you some clues to some cancers, right? Like a patient with 60-pack year history of smoking, or a little bit of hemoptysis, or a little bit of blood in the, some kind of a risk factor related to cancer. And what they want you to also realize is that membranous is something which is somehow, of all the nephrotic syndromes, more commonly associated with thrombosis. And one of the most common thrombosis, and we don't know why, is renal vein thrombosis. So if they give you that the patient has a known diagnosis of membranous and is now coming in with flank pain, blood in the urine, and high LDH, they're taking you towards renal vein thrombosis or renal infarction, right? High LDH because tissue is dying. Hematuria, this is again from thrombosis and infarction, and flank pain. So flank pain, hematuria, high LDH is renal infarction. And in a patient with membranous, you should be thinking about renal vein thrombosis. They love this. I don't know why. I've put 3 stars there. They really like it. But again, it's a good pattern recognition in the right setting. A nephrotic syndrome associated with diabetes. Of course, diabetic nephropathy initially starts with microalbuminuria, which is followed by heavy proteinuria. All of you know that, again, there are 2 or 3 simple questions. Don't overthink. If you have diabetic nephrotic syndrome, ACE or ARB is the treatment of choice. But in 30% of diabetics, it could be something other than diabetic nephropathy which is causing nephrotic syndrome. So if you have a rapidly progressive proteinuria, or there's no eye disease and the patient has nephrotic syndrome, which is very atypical, that you have no diabetic retinopathy and you have nephrotic syndrome, you got to think about that this patient could have something else, because these patients can still have membranous, they can still have other diseases as well. So in patients who have no retinopathy, I would think about other causes of nephrotic syndrome. And this is one of their favorites. I can promise you, you're going to have at least 2 to 3 questions related to amyloid or multiple myeloma. They love it. There are 2 types of amyloidosis, right? One is the light chain AL, which is associated with multiple myeloma, and the other one, which is uncommon now, is the AA, which used to be related to long-standing rheumatoid arthritis or inflammatory bowel diseases. But with the new treatment options, this has gone down. They'll give you multiple polls to figure out multiple myeloma. The biggest one would be discrepancy in urine dipstick and urine protein to creatinine ratio. So if you do a dipstick and it shows no protein, like negative, but when you do a urine protein to creatinine ratio, it comes back as 7. Its diagnosis is actually made, right? Because the dipstick does not pick up light chains. Dipstick does not pick light chains. So if you're worried about light chains, do a urine protein to creatinine ratio, right? Dipstick only picks up albumin, right? So the clues are going to be renal failure and high calcium, along with back pain and elderly, discrepancy in urine dipstick and urine protein to creatinine ratio. Actually, again, low in iron gap is sometimes a clue towards paraproteins. And another big clue is total protein to albumin ratio of more than 2:1. Generally, the ratio is what? 2:1, right? So if your albumin is 6, generally I would expect your, not albumin, if your protein is 6, I would expect your albumin to be 3. But if your albumin is 3 and your total protein is 8.8, you should start thinking about, oh my God, is there some paraprotein floating around? It could be polyclonal protein from inflammation, but at least a thought should cross your mind, is it possible that there's paraprotein floating around? So you will be ordering SIFE, UFE, and serum free light chain assays to confirm that. So how would you actually approach nephrotic syndrome? Clues, clues, clues. If it is a young adult and kid with nephrotic syndrome, think about minimal change disease. Remember Hodgkin's and NSAIDs. FSGS clue would be African American. The major reason is genetic, some other associations. If it's a Caucasian adult and there's a history of cancer, what is the most likely diagnosis? Membranous. If there's MPGN, of course, the clue would be low complements, right? Because all these other diseases have normal complements, and the association is with Hep C, which we've already talked about. So summary principles I've already mentioned. Look at whether it's nephritic or nephrotic. Just remember the key features and go on. An 84-year-old male with type 2 diabetes and hypertension presents with severe low back pain and increasing confusion. 3-month history of 20-pound weight loss, frail, and generally looks decompensated with normal vital signs and point tenderness over L3. These are the labs. I'm going to let you read it. Okay, which of the following is the most appropriate next step in this patient's care? You guys all got it. So there were so many clues. It was full of clues. There was discrepancy between urine and urine dipstick and the protein level. The albumin to protein ratio is high. So the whole point is it's not going to be one clue. There's going to be multiple clues. So you've got to miss multiple clues to get questions wrong. What about this one? 64-year-old with hypertension, hyperlipidemia, new onset lower extremity edema, weight loss of 5 pounds, blood pressure is fine, slightly obese, he's got 3+ pitting edema, creatinine is fine, albumin is low, cholesterol is very high, fasting glucose is 98, 4+ protein, micro of the urine shows fat droplets, so lipiduria. Urine protein to creatinine ratio is 7.5, hemoglobin is 9.8, and stool occult is positive. What is the most likely diagnosis? Great. So they want you to pick, if I'd given you an 80-pack year history of smoking, or there was a nodule discovered here, I gave you hemoglobin was low and stool occult was positive. Probably he hasn't had screening. So I'm taking you towards membranous nephropathy. So the answer for the one other question which they can actually also test is, what would you do if you find out that somebody has membranous nephropathy? So the answer should be age and risk appropriate cancer screening. Age and risk appropriate. You're not going to go ahead and do a PET scan and look everywhere. Don't do that. What the board wants you to answer is age and risk associated cancer screening, because of the huge association between cancer and membranous. So I'm to be switching modes from nephrotic, nephritic to stones. That's not true. I thought it was funny, probably not. Okay, afflicted. So the board loves it because it's very, 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 very common. So if there are 100 males here, the bad news is 12% of you are actually going to get a stone sometime in your life. Women are a little lucky, 6% a lifetime kind of risk. And the bad news is if you have one stone, the risk of actually having another stone in 5 years is very, very high, 30 to 50%. So if you have a stone now, there's a 50% chance that you're going to have a stone again. But the good news again is you can actually reduce this risk by 50%, which is a huge, huge, huge reduction by medical management, including diet and the medications which I'm going to mention. 80% of the stones contain calcium, and calcium oxalate is the most common stone. The most common stone is calcium oxalate. If you are thinking about stones, you got to think about, this is how I think about, is it calcium-based or everything else? The most common in calcium-based, as I told you, is calcium oxalate. But if you have, this is, again, a very important clue which boards loves to test. If you have a stone which is predominantly calcium phosphate, which is uncommon, you should be thinking about distal renal tubular acidosis. And we'll be talking about distal renal tubular acidosis as well, because they love this. Everything else, uric acid stones are 10%, and the incidence is actually, and prevalence is increasing because of obesity, diabetes, insulin resistance. Actually, it's directly linked. So the uric acid stones are actually increasing in prevalence. They are not picked up. Uric acid stones are not actually picked up by your x-rays because they are radiolucent. They don't have calcium in it. You're going to miss it. So that's why a KUB is not sufficient for the first time. You got to do a non-contrast CT. Struvite stones are 10%, which are associated with urease-splitting organisms like Klebsiella, Proteus, or Staph saprophyticus. And we're not going to talk about those two. You got to know about drug-associated stones. The two big drugs are triamtrene and indinavir, which is part of highly active retroviral therapy. And you got to also remember is ascorbic acid. It is vitamin C, right? Everyone is like, anytime you have a little cold, you start pumping in huge amounts of, 2 grams, 3 grams of actually vitamin C. It can actually, if you have a propensity for stone, it will give you stones because ascorbic acid is converted into what? Oxalate, right? So please avoid taking vitamin C if you're at high risk of stones. And again, if you don't need it, don't take it, How do you think about stones? You think about, if you go back to biochemistry and if you took some water and you start mixing in salt, what happens? You mix in a salt, you dissolve it, it dissolves. You mix more salt, it dissolves. But after some time, the saturation point is reached, and if you add more salt, it'll start crystallizing. And actually, that's what happens with crystals, which finally aggregate and form stones as well. So there are 3 things in your urine which promote stones: calcium, oxalate or hyperoxaluria, or high uric acid in the stone. So these 3 things, calcium, oxalate, and uric acid, if they're high in your urine, they are going to form microcrystals. And all of us have these things in our urines. But why don't we form stones? Because there's also citrate present in our urine, which prevents calcium and oxalate or calcium and uric acid to come together. So citrate prevents aggregation of crystals. So all of us have citrate, which kind of prevents this aggregation to take place. So when do you form stones? Either the promoters are high or the inhibitors are low, right? It's simple. If the calcium, oxalate, or uric acid is going up, or the inhibitors are, and one of the biggest inhibitor is citrate, is going low. And of course, low urine volume, because what is low urine volume going to do? It's going to concentrate all these factors, right? So low urine volume is a risk factor for pretty much you name the stone, right? Because it increases the concentration. The biggest risk factor you got to know is high calcium in the urine. One of the most important, and the most important one which the board loves to test, followed by hyperoxaluria. That means high oxalate in the urine, right? So these 3 are promoters, right? High calcium, high oxalate, high uric acid in the urine. And what about low inhibitor? That means if you have low citrate in the urine, right? No new information yet. So what is idiopathic hypercalciuria? That means your serum calcium is normal. I check your blood calcium level, it's totally normal. But when I check a urine calcium level, it is higher than 300 in men, or if it's higher than 250 milligrams in women, we call it idiopathic hypercalciuria, right? It's not idiopathic hypercalciuria if your serum calcium is 11 from malignancy or primary hyperpara. I know why the urine calcium is high, because your serum calcium is high, your kidney is trying to get rid of it, right? So it's normal calcium levels after you've done the workup for hypercalcemia and your urine calcium is still high. We call it idiopathic hypercalciuria. And which drugs are effective in decreasing the calcium in the urine? Thiazide diuretics. You got to know it, right? Hydrochlorothiazide, chlorthalidone, indapamide, all of them are thiazide diuretics. And about 10, 15 years back, we used to figure out, we used to spend a lot of time trying to figure out why is the calcium high in the urine. And then is it coming from the bones? Is it coming because kidneys are leaking calcium? What's happening? Over the last 10 years, our practice has changed. Now we know that finding out doesn't make much difference. All we need to know is what worsens this high calcium in the urine, and there's very clear studies which show that if you eat a lot of salt, or if you're on Burger King diet, or if you're having a lot of animal protein or a lot of sucrose and fructose, calcium goes along with it. So fructose, sucrose, sodium, animal protein, higher your sodium intake, higher your calcium in the urine. So the major advice is what? Decrease animal protein, decrease sodium in the diet, reduce sucrose and fructose intake, and if nothing works, add thiazide diuretics along with dietary changes. Make sense? So hypercalciuria, we talked about what you got to know the drug which works against high calcium in the urine, and that is thiazide diuretics. Now, the second big risk factor is high oxalate in the urine. What causes high oxalate in the urine? If you're, oxalate-rich foods, everything which is, which tastes good, like chocolate, nuts, rhubarb. I don't know who likes rhubarb, but I do. But that's very high in oxalate. Spinach is very high in oxalate. So if you're having a very high oxalate food, you have genetic causes. But the big one here is this too. And we'll talk about this one right here. So if you are eating oxalate-containing foods, it gets reabsorbed in your gut. If you're actually having calcium in your diet, calcium attaches to the oxalate and it is excreted in your stools. So what used to happen, or what was happening 15 years back was, we figured out that one of the big risk factors for stones was what? High calcium in the urine, right? So what was the advice which all the patients started getting? Decrease the calcium in your diet. What did we start seeing? Increasing stones. Why? Because now there was no calcium coming in with your diet. Oxalate was free to be absorbed. So calcium was being actually reabsorbed back in the gut because there was no, not calcium, oxalate was being reabsorbed in the gut because there was no calcium to bind with it. So I'm going to show you one study with that too. So our advice for hyperoxaluria is to reduce oxalate-containing foods like spinach, rhubarb, beetroot, nuts, chocolates, and this is what the board loves to test you on, is avoid low-calcium diet. Avoid low-calcium diet, because if you look at this study, and again, this is the most cited study, is as your calcium intake with diet goes up, your risk actually decreases of stone formation. So it's calcium in the diet. Calcium in the diet should be good. So what I advise my patients is have a little bit of yogurt or cheese with your meals. That doesn't mean take calcium supplementation, because there's very clear risk of actually increased risk of stones with calcium supplementation, right? How often are you going to take the pills with your food every time, every day? It's not going to happen. So actually, people have done studies, and the risk with calcium supplementation for stones is high, but you should be advising uh, adequate amount of calcium with your diet. An adequate amount of calcium is at least 700 milligrams for stone prevention. So adding 1 cup of yogurt or 2 cups of yogurt with each meal, but no calcium supplementation. Risk factor for uric acid stones. Again, I told you uric acid stones are becoming more and more common because of the diabetes and obesity epidemic. Uh, One thing which is very interesting with this is, contrary to the belief that the major risk factor for uric acid stone is high uric acid in the urine or hyperuricasuria, the biggest risk factor is acidic urine pH. Because if your pH is less than 5.5 in the urine, this reaction goes towards uric acid, which is not soluble. So if your pH in your urine is acidic, this reaction moves towards uric acid, which is not soluble, and you have more crystal formation and more stones. It's really, really interesting. So if you were asked a question, this is actually one kind of stone. I tell my patients I can actually dissolve it in 2 to 3 months if you follow the medication regimen. Because this is very pH dependent. If I maintain a urine pH above 6, I can start dissolving the stone because the uric acid is going to convert into urate, which is soluble, and it's going to come out. Okay, so the biggest risk factor is what for uric acid stone? Acidic urine pH, and after that, of course, high uric acid in the urine plays a part too. So what are you going to do for uric acid stones? I will give them, my first strategy is to get the urine pH above 6. How do I do it? Potassium citrate. So first, citrate is alkaline, so it's going to alkalinize your urine. And actually, citrate as acid is good, right? Because citrate actually prevents aggregation of stones as it is. And if the uric acid in your urine was high, you can actually give them allopurinol, and of course improve the metabolic risk factors. So actually, if you look at a stone treatment, there are only 2 drugs or 3 drugs maximum, right? There's nothing else. We have major part is what? Diet, diet, diet. So rather than calling diet and dietary advice, it should be dietary prescription, because that is what is more effective in reducing the risk of stones. So the 2 major medications which are actually available are thiazide diuretics. When do you use it? If you have high calcium in the urine. And the other one is what? Potassium citrate when you have low citrate in the urine. And the third one is what? Allopurinol if you have high uric acid in the urine. There's nothing else. So what is the dietary prescription? The dietary prescription should be to maintain a urine volume above 2 liters. To maintain a urine volume above 2 liters, you actually have to consume 3 liters of fluid. So I generally show them the bottle of, what does 1 liter mean? What does, So you got to actually at least consume 3 to 3.5 liters of urine to, not. Okay, that's pretty bad. 3 to 3.5 liters of fluid to have at least 2 liters of urine output because of your insensible losses, right? If you have high urinary calcium, I told you urine calcium is directly linked to sucrose, fructose, sodium intake, and animal protein intake. So you got to reduce your animal protein intake, reduce your sodium intake, reduce your sucrose and fructose. So that means, stop going to Burger King or McDonald's, and your urine calcium is going to come down. High urinary oxalate, avoid high oxalate containing foods, and this is what the boards loves to test you. Don't ask them to decrease the calcium in their diet. Actually tell them to have adequate dietary calcium, because that needs to bind with the oxalate so that it can be excreted in the stools. And please, vitamin C is converted into what? Oxalate. So stop even minor amount of vitamin C supplementation. High uric acid is present in red meats. It's controversial, but reduced purine intake, so that means decreased red meats. If you have low urinary citrate, what are you going to do? Citrate is present in fruits and vegetables, so that's what you're going to tell them. Increase your vegetable and fruit intake and reduce your animal protein intake, which was actually mentioned earlier on too. So what do they want you to know for boards? Calcium oxalate are the most common type of stones. These are the same stones which are associated with primary hyperparathyroidism too. Calcium phosphate stones, if you see, you should be thinking about distal renal tubular acidosis, which we're going to talk about. Uric acid stones are increasing. The major risk factor is what? Low urine pH. And of course, it is associated with diabetes and obesity. These stones are radiolucent. They're not going to be picked up by your plain X-ray. Treatment is what? Increase the urine pH by giving potassium citrate. Struvite stones are these big honking stones, like these are called staghorn calculi, which just fill your pelvis. Huge, huge, huge stones. They are associated with urease splitting organisms like Proteus, Klebsiella, Staph saprophyticus, and cystine stones, which are very, very, very uncommon. But again, if they show you a crystal with 6 sides, hexagonal, again, it's less than 1%, but sometimes they love very rare things too. So if they show you a hexagonal crystal, they're actually trying to make sure that you know this is how a cystine crystal looks like for stones. Probably they're not going to ask you that. So switching gears, we're going to talk about metabolic acid disorders, and I'm not, this section, I'm not going to be covering your approach to metabolic acid-based disorders, but my whole idea is going to be focus your attention to something which is very important, and they really test you quite a bit on it. It's called renal tubular acidosis. Again, you don't see that that often, but that is a topic which is kind of tested on the boards. So we'll kind of try and pick on how to maneuver that. So metabolic acid-based disorders, again, if you have metabolic acidosis, that means your pH is low and your bicarb is low. You got to think about, of course, is it high anion gap versus normal anion gap? And for boards, if your anion gap is normal, so all of you need to know what is anion gap and how do you calculate it. But if your anion gap is normal, for all practical purposes in the boards, they are either trying to test whether you know that it is renal tubular acidosis or is it diarrhea. And again, simplistically, it makes quite a bit of sense that, why do we need to know any details if it is diarrhea? If, the history should be telling you. But most of the times, they're going to actually not give you a very clear-cut history of diarrhea, or it could be that somebody is using some laxatives or something like that, and you need to differentiate between these two conditions. Metabolic alkalosis, that means the pH is high and your bicarb is high. So the mantra is, again, hopefully you're not getting post-traumatic stress disorder here with this equation, but the bottom line, I just wanted to just keep on, just look at it, but all you need to remember is ABCD, right? The main thing here is that A is pH, acidity, right? And what I'm trying to show you is pH is inversely proportional to CO2. That means CO2 is an acid. If CO2 goes up, pH goes low. So CO2, and I think this is sometimes very confusing, right? But if you remember ABCD, and A is pH, B is bicarbonate, CD is carbon dioxide, you will never forget it, right? That CO2 goes up, pH goes down, CO2 goes low, pH goes up. So CO2 is an acid. Right, that is one major key, and you'll see pH is directly proportional with bicarb. If the pH goes low, the bicarb goes low. What is it? It's metabolic acidosis, because the primary change is happening in the bicarb. If the bicarb goes high, what should happen to the pH? pH will go up. That is metabolic alkalosis. If the primary changes are happening in bicarb, we call it metabolic disorders. If the primary changes in the pH are driven by carbon dioxide, it is respiratory. Just remember, pH and CO2 are inversely proportional, right? A, B, C, D. Okay. This is, again, it's a very quick descriptive slide, which is again telling you exactly what I just told you previously. Increase in bicarb cause increase in pH. This is metabolic alkalosis. And again, decrease in bicarb causes decrease in pH. It's metabolic acidosis, and CO2 and pH are inversely proportional, right? So the primary disorder should be very easy to figure out, because all you got to do is first look at the pH, right? If the pH is acidemic, that means if the pH is less than 7.4, let's say it's 7.32, I know that the patient's blood is acidemic. Now I want to see whether it's metabolic or is it respiratory. If the bicarb is also low, I know it is metabolic. On the other hand, if the CO2 is high, I know it is respiratory. So some of the simple problems are going to be very easy, but the boards is still going to test you on that. And this slide serves one purpose. So we've already figured out what the primary disorder is, right? Metabolic acidosis, the pH will be low, the bicarb will be low. The only reason I've put this slide on is to show you what happens with compensation. And if you just look at the slide, you'll see a pattern recognition, right? What is the pattern recognition? That bicarb and PCO2 travel together. Both these things travel together. If the bicarb is going down, PCO2 should go down. They always travel together, right? So the compensation always drives these two things together. So if you have a patient whose bicarb is down, but the PCO2 is actually up, you already know that there are two disorders going on, right? Because actually, if it was just compensation, they should be going in the same direction, right? If they're going in opposite direction without knowing what, no calculation, nothing, I know that there are two disorders. If the bicarb is low, so let's say you start with a pH which is 7.3, you know that the patient is what? Acidemic. You look at the bicarb is low, you're like, oh, this is metabolic acidosis. What should the PCO2 be doing? It should be going low too, but rather than being low, it is high. So you already know that the patient has both metabolic acidosis and respiratory acidosis, right? So bicarb and PCO2 travel together. Third thing, again, I'm not going into detail on how to actually interpret acid-base disorders, but for board's purposes, in every acid-base question, please calculate an anion gap. Gotta calculate an anion gap in each and every case, regardless of the pH. Because if your anion gap is more than 20, you have anion gap metabolic acidosis. If your gap is more than 20, you have anion gap metabolic acidosis. And if you have anion gap acidosis, and if you love mnemonics, these are the mnemonics. You can read it, but I'm not a mnemonic person, because my problem with mnemonics is you remember the mnemonic, but you don't know what it stands for. Like, oh, there's mud piles there. What is, it's this. But again, if you're a mnemonic person, I've got nothing against you, but I've put two different mnemonics, whatever you want to choose. But my approach is, all you have to remember is few things. You got to strain your mind a little bit. If you just remember that ketoacidosis can cause an anion gap, right? And then you have to think about what can cause ketoacidosis. There are only three things: diabetes, alcohol, starvation, right? For all these three things, you're still going to check beta-hydroxybutyrate. So 3 diagnoses, 1 test. And a little bit of thinking: is it diabetes, is it alcohol, is it starvation, right? All you remembered is ketoacidosis. What are the 3 things which cause it? And you're going to do 1 test. The other big one is what? Lactic acidosis. And then you got to remember that there are 2 or 3 types of lactic acidosis. Type A is the most common which we see, right? Type A lactic acidosis is hypoperfusion, mismatch in supply and demand of nutritional supply or oxygen, right? Lactic acidosis, you're going to check what lactic. So that's type A lactic acidosis. Type B lactic acidosis is what you see when there's a problem with mitochondrial oxidation chain. This is what happens if you have thiamine deficiency, metformin, or we used to use the drug zidovudine for heart. That can cause it, and there are certain other drugs which can cause it. But the big ones are thiamine deficiency or metformin, which the board loves to tell. But lactic acidosis, what are you going to check? Lactate level, right? So your two tests you've ordered are what? Beta hydroxybutyrate and lactate. Third one, which you got to remember, is if you have kidney disease. Chronic kidney disease in early stages causes non-anion gap metabolic acidosis, but once your kidney disease is severe enough that you start accumulating phosphorus, sulfates, so these are phosphoric acid and sulfuric acid from the diet, your anion gap starts going up. So by the time you have stage 4, stage 5 kidney disease, you'll start seeing elevation in anion gap. Or if you have acute kidney injury and you're accumulating phosphates and sulfates, you're going to have increase. So what are you going to check? BUN and creatinine, right? So beta hydroxybutyrate, lactate, BUN and creatinine. And then you got to strain your mind toxins. You got to think about, oh, toxins can cause an anion gap too. Then you got to think about what are the toxins, right? What are the toxins? One is, the board loves this, is methanol, right? Methanol, you got to look at, it along with anion gap, it also gives you an osmolar gap. They'll tell you what the osmolar gap is. Or they'll give you everything to calculate an osmolar gap. So if you have anion gap, osmolar gap, and you've got I changes, it's methanol. If you have anion gap, you've got osmolar gap, and you have oxalate crystals in the urine. Somebody has had what? Somebody has consumed antifreeze, ethylene glycol, right? And if you have a combination of anion gap associated with respiratory alkalosis, that means somebody is coming in with rapid, initial thing is what? If you consume a lot of aspirin or salicylates, what happens? The respiratory centers in the medulla are activated, so you start breathing fast. So you develop what? If I'm breathing fast, what's going to happen to my CO2? Is going to go down. So my CO2 is going down. What is going to happen to my pH? Is going to be up. So I'll have respiratory alkalosis. And after that, what happens is your salicylates in the stomach start getting absorbed even more, and you start actually accumulating salicylates in the blood, so you start getting anion gap acidosis. So a combination of anion gap acidosis and respiratory alkalosis should at least make you think about, could this be salicylate poisoning? Make sense? Okay, all you got to remember is what? Ketoacid, lactic acidosis, kidney disease, and toxins. And then you got to strain your mind what toxins can cause anion gap. Ethylene glycol, methanol, salicylates. For ICU docs, you also got to know propylene glycol, which is actually present in a lot of solvents. So again, if you're getting a huge dose of Ativan, Ativan is mixed in propylene glycol, and if you are getting Ativan for a long time, propylene glycol in Ativan can actually accumulate and cause anion gap as well. But uncommon, but if you want to make a note of it, that would be awesome. Okay, my main thing here was, I know acid-base is okay, but what they want you to know or they like to test you on is renal tubular acidosis. So when should you worry about renal tubular acidosis? You should suspect if the patient has, or your board question has, somebody with metabolic acidosis, which is non-anion gap. And most of the non-anion gap metabolic acidosis, it's a quick clue, is going to be what? If you look at the chloride level in non-anion gap acidosis, what is it going to be? It's going to be high. So again, if you're just quickly looking at the labs and the chloride level is high, it kind of is, even without calculating an anion gap, I can tell you most likely it's going to be non-anion gap metabolic acidosis. Why? Because how is the anion gap normal in non-anion gap metabolic acidosis? The chloride goes up, bicarb goes low, it cancels out, so you have a normal anion gap. Right? That's what is happening in diarrhea. Right? You're losing bicarb in the gut, but you're reabsorbing chloride back. Chloride bicarb exchanger. So bicarb gets lost, chloride gets absorbed, there's no change in anion gap. So when should you suspect renal tubular acidosis? If you have hyperchloremic, non-anion gap metabolic acidosis without any evidence of diarrhea, you should start suspecting what? Renal tubular acidosis. Okay. What is, all of you know about anion gap in this blood, but what about urine anion gap? If the board question gives you a urine sodium, urine potassium, urine chloride, they want you to check a urine anion gap. Why would they give you these labs? That doesn't even make sense. What would you use it for? Right? So if in a question you're getting urine sodium, potassium, urine chloride, they want you to check a urine anion gap. And you got to know what urine anion gap is to actually figure out what the answer to the question is, too. So let's say I don't like you and I give you a bottle of hydrochloric acid to drink, right? What's going to happen? You're going to drink that hydrochloric acid, you're going to absorb, hopefully there's no, let's say your gastric mucosa tolerates that fine. You're going to absorb that acid, and what is your kidney going to do? Your kidney doesn't like acidic environment. Your body doesn't like acidic environment. What is your body going to try and do? It's going to try and get this H plus excreted in the kidney, right? That H plus, with whatever I'm consuming, is going to go in the kidney, and H plus can't go alone in the kidney. It combines with what? Ammonia. It becomes NH4 plus, ammonium. NH4 plus can't go alone, otherwise you'll have sparks in the urine. It combines with chloride. So if my kidney was fine, I would be excreting a lot of ammonium, NH4 plus. And that NH4 plus is going to combine with what? Chloride. So if my kidney was fine, my chloride level is going to go really, actually, it's going to go very high, right? Because it's ammonium is going up. Ammonia has to combine with chloride, so the chloride level is going to be up. So if the chloride level is up, what is this urine anion gap going to look like? If this level is higher than sodium and potassium, your urine anion gap is going to be negative. So a negative urine anion gap means my kidney is doing what it needs to do. It's trying to get rid of that acid. Where is that acid excreted in the kidney? In the distal tubule. And the distal tubule is where all the magic happens for getting rid of this extra acid. On a normal American diet, me and you are consuming about 1 milliequivalent per kg of acid every day from animal proteins, right? So if you're 60 kilos, you're eating 60 milliequivalent of acid every day. And if your kidneys were not good, you can't get rid of the acid which you're eating, you'll become acidotic. That's what happens in chronic kidney disease, right? You start becoming acidotic because you're eating acid, your kidney can't get rid of it. But where does your kidney get rid of this acid from? In the distal tubule. So all the acid which you're eating gets rid of in the distal tubule, right? And your kidneys can get more animal protein you eat, more it can excrete out. So kidney has a remarkable capacity to get rid of the acid which we eat, right? So if you start eating a lot of actually acid, ammonium will go up, chloride will go up, your urine anion gap is going to be negative. So urine anion gap being negative is telling you that the kidney is fine. The distal part of the nephron is doing its job. Whereas in distal renal tubular acidosis, I don't think we should even call it type 1. We should only call it distal because we know what the function is. This is where the kidney gets rid of this acid. So if your kidney can't get rid of that acid, what's going to happen? If I eat a lot of acid, my kidney should be getting rid of this acid. If I can't get rid of this acid, ammonium is going to go down, chloride is going to go down. What is the gap going to be? Positive. So urine anion gap, which is positive, means the distal part is not doing its job. In diarrhea, the kidney is fine, so urine anion gap is negative, right? Because kidney is trying to get rid of that extra acid. In diarrhea, the kidney is doing its job. If I consume a lot of acid right now and my kidney is fine, my urine anion gap is going to become what? Negative. But if there's a problem in the distal nephron, I can't get rid of H plus, my urine anion gap is going to be positive. Ideally, the easiest thing would be to check a NH4 plus level in the urine, ammonium level, right? Because if there's a huge amount of ammonium in my urine, that means my kidney is fine. But to check NH4 plus, it's a really, really, really difficult lab test to check. So rather than NH4 plus, we rely on urine anion gap. So if you can't remember this, just just remember distal renal is kind of positive. We made it up. So it's something visual. If you forget the mechanism behind it, but again, if you understand it, it's really, really, really hard to get this wrong. Diarrhea, the urine anion gap should be what? Negative, because the kidneys are doing its job by getting rid of ammonium chloride. Okay. Anytime you see a distal RTA, boards loves Sjogren's syndrome. So the most common cause of distal RTA as far as boards is concerned, and actually in clinical practice too, is Sjogren's syndrome. Sometimes the initial presentation of Sjogren's syndrome, rather than keratoconjunctivitis sicca, right, dry mouth, dry eyes, is actually distal RTA. Distal RTA could be the first presentation rather than your classical dry mouth, dry eyes presentation. Let's go with distal first. Distal RTA, we talked about classical, it's associated with Sjogren's syndrome, can also be associated with lupus. Urine anion gap is positive. We already talked about another clue is going to be that distal RTA is associated with stones. And what are the most common stones? Phosphate stones. Now, proximal RTA, which is type 2, the problem is in the proximal nephron. That's where all the bicarb is absorbed. It's the proximal nephron where we reabsorb all the bicarb which is filtered. So if there's problem with the proximal nephron, what's going to happen? You are going to lose a lot of bicarb. So if you have a lot of bicarb in the urine, what is your urine pH going to be? Is it going to be acidic or is it going to be alkaline? Alkaline. So if your urine pH is 6.5 or 7, there's only few things which can cause a urine pH of 7. Actually, only two things. Either there's bicarb in the urine or there's urease splitting organism, right? Like Proteus, Klebsiella, Staph saprophyticus. Only thing which can cause a urine pH of 7 or high is urease splitting organism or bicarb in the urine. Bicarb in the urine should be fine if your serum bicarb is 36, right? If your serum bicarbonate is very high, your kidneys are getting rid of the bicarb because they want to get the bicarb close to 24. But if your serum bicarb is 18, right, that means you're acidic. Why should you be losing bicarb? Right? And we are talking about acidosis, right? So if you have a patient who's acidotic and your urine pH is 7.5, it's telling you you're losing bicarb in the urine when you shouldn't be losing bicarb in the urine. And where do you lose bicarb from? Proximal. So the most common cause is what? Multiple myeloma and drugs. One of the most common drugs is, now we are using quite a bit in practice, is what? Topiramate. The other one which can also cause this is what? Acetazolamide. That also actually blocks the bicarb reabsorption. Both proximal and distal RTAs are associated with hypokalemia, whereas type 4 RTA. How many of you remember type 4 RTA? Oh, so it's again PTSD, right? Okay, so type 4 RTA is nothing but low renin, low aldo, hyporeninemic hypoaldosteronism. And it's, if you just remember that it's low renin and low aldo, and the most common cause is diabetes, 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 why do you see it in diabetes? Because in diabetes, you have autonomic neuropathy, right? So if you have autonomic neuropathy, it's the autonomic nervous system which actually sends signals to release renin in the kidney. So if your autonomic nervous system is not working well, what's going to happen to the renin? Renin is not going to be secreted. If renin is not going to be secreted, angiotensin 2 is going to be, angiotensin 1 is going to be low, angiotensin 2 is going to be low, aldosterone is going to be low. And if aldosterone is low, what does aldosterone do in the kidney? It reabsorbs sodium. I showed you in the initial slide, right? It's reabsorbing sodium. And if you're reabsorbing sodium from the urinary side into the blood side, the urinary side becomes what? Negative. So urinary side becomes negative because you're reabsorbing sodium, and you can't have sparks in your urine, right? You don't spark it out. So if you can't have sparks in the urine, what happens? So you're reabsorbing sodium, urinary side becomes negative. To balance the charge, what comes out? Potassium and H+. Right? So aldosterone helps in getting rid of potassium and H+. So if you don't have enough aldosterone, what's going to happen to the potassium? Go up. What's going to happen to the H+? You can't get rid of H+ properly. Your H+ is going to go up. You're going to develop metabolic. That is what is type 4 RTA in diabetes. Low renin, low aldo. Since there's no aldo, you can't get rid of acid and potassium, so you are hyperkalemic. And your urine anion gap is positive. Why? Because you can't get rid of H+ in the distal tubule because there's no aldosterone. Make sense? So how do you differentiate this distal RTA from type 4 RTA? Distal RTA will have hypokalemia, whereas type 4 RTA will have? Make sense? So type 4 RTA shouldn't be a problem. What's the most common cause? Diabetes, diabetes, diabetes. Of course, HIV and obstruction can cause it too. But diabetes is the major cause. And the most common cause they're going to test you on the boards for type 1 or distal RTA is Sjogren syndrome. So if you understand it, it's just really, you don't have to memorize it. Okay, a 26-year-old Caucasian female referred for further evaluation of hypokalemia and acidosis. She was in her usual state of excellent health until 4 months ago when she developed dry mouth and muscle weakness. She was found to have a serum potassium of 2.8 and a bicarb level of 15 during her lab check. She was treated with oral potassium and bicarbonate supplements, and then she stopped taking these medications. 6 weeks later, she developed myalgias and collapsed due to profound weakness. She was found to have a bicarb level of 14 and a serum potassium of 2.0. ABG shows a pH of 7.29, so she's acidemic. PCO2 is 30 and PO2 is 100. Urine potassium is 46. Urine sodium is 36. Urine chloride is 42. So if they give you these three, they want you to check something. Urine osmolality is 580, so they're trying to confuse you by giving some extra stuff too. Urine analysis shows a pH of 6.8, no casts. So just quickly going back, if you were checking a urine anion gap here, what is the urine anion gap? It should be very, all you need to know is it positive or negative? Which of the following is the correct diagnosis? The other thing would be don't overthink the questions. Sometimes they're asking something very awesome. It's not type 4, right? Because there's no hyperkalemia. Type 4 has to have hyperkalemia. Urine anion gap would be negative. This is the only one with, and there's nothing. Who's that here? There's nothing called adrenal tubular alkalosis. Type 2 RTA or proximal RTA, the urine anion gap should be what? Negative in that too, because the distal part is fine. So the only thing here is distal RTA. I think one of the points why 14% might have gotten confused is the urine pH of 6.8, and sometimes the urine pH could be very variable in distal RTA as well. Most of the time, you'll see a urine pH of between 6 to 6.5 in distal RTA, but sometimes it could be up to 6.8 as well. But urine anion gap should be the first thing which actually tells you what is the problem. And urine anion gap is going to be negative in proximal RTA and diarrhea. It is going to be positive in type 4 and type 1 or distal, but what will differentiate this and this? Awesome. You guys are ready. Okay, metabolic alkalosis. So if you have, exam likes metabolic alkalosis, but they like one very specific aspect of metabolic alkalosis. So what they like is urine chloride, because otherwise there's no utility for urine chloride other than assessing metabolic alkalosis and use in urine anion gap, right? In urine anion gap, you need urine chloride, right? Because it's sodium plus potassium minus urine chloride. The other utility is metabolic alkalosis. So if you have metabolic alkalosis, that means pH is, let's say, 7.45 and your bicarb is 33. What you are trying to do is trying to find out whether this metabolic alkalosis is because of volume depletion, right? Because anytime you are volume depleted, you are going to develop metabolic alkalosis. And how does that happen? So if I start giving you a lot of diuretics, like, I want to give you, somebody comes in with some cosmetic edema in the lower extremity, and I'm like, I'm going to make your legs pretty. I'm going to give you a lot of diuretics, right? So I'm giving you a lot of diuretics. You become volume depleted. If I'm volume depleted, what happens to my renin-angiotensin system? Goes up. My aldosterone goes up. What is aldosterone going to do? It's going to get rid of potassium and H plus too, right? Because what does aldosterone do? Tries to reabsorb sodium but gets rid of potassium and H plus. If I'm getting rid of H plus, what's going to happen? I'm going to develop alkalosis, contraction alkalosis, right? Because aldosterone is very high. Now, I have alkalosis from volume depletion. And I told you, if you have pre-renal AKI, which test do we do in the urine to differentiate between pre-renal and other is urine sodium, right? Or fractional excretion of sodium. But now I'm going to tell you that if you have volume depletion and alkalosis, urine sodium might not be the right test to do. Why is that? Because now your serum bicarb is what? 30, 32, right? From contraction alkalosis. And now your body doesn't like a serum bicarb of 32. It wants to get it back to 24, which is, or 24 to 26, whatever your normal is. And it starts getting rid of that bicarb in the urine. And the bicarb is what? Negatively charged. It can't go alone. What does it go along with? It goes along with sodium. So in metabolic alkalosis, your urine sodium can be high because the sodium is combining with bicarb in the urine. So in that case, urine chloride is a better test to see if you're volume depleted or no. So your urine chloride is going to be low if you're volume depleted. It's going to be high if the contraction, if the metabolic alkalosis is not because of volume depletion, but it is because, let's say, related to a tumor in your adrenal gland. Right? Because if you have a tumor in your adrenal gland or an adenoma, what is it going to secrete? Aldosterone, because it's an aldosterone secreting tumor. And if the aldosterone is high, what is it going to cause? It's still going to cause metabolic alkalosis, because aldosterone is going to reabsorb sodium, cause hypertension and volume overload, and it's going to get rid of H+. So the major factor if you have alkalosis is differentiating whether the alkalosis is because of volume depletion. In that case, what's going to happen to your urine chloride? Low. Whereas if it's an aldosterone secreting tumor or something else, the urine chloride is going to be high. And we're going to talk about this in hypertension as well. So if you didn't fully get it, we'll revisit it pretty soon. Clues to acid-base disorders. If you have a normal ABG and an increased anion gap, you should be thinking about mixed metabolic acidosis and alkalosis. If you have a low anion gap of less than 8 or actually less than 4, think about low albumin and a paraprotein like multiple myeloma. If you have an osmolar gap of more than 10, think about methanol if it's associated with blindness, ethylene glycol if it is associated with oxalate crystals. And you got to make sure that you correct for normal drinking alcohol too, because most of the labs actually corrected for ethanol levels already. Isopropyl alcohol or your wiping alcohol gives you an osmolar gap but does not give you acidosis. So if you consume a lot of isopropyl alcohol, all you'll get is an osmolar gap but no anion gap acidosis. Okay. Take a deep breath. Okay, moving on to hypertension. Oh, I don't know why I put it here. JNC 8. And then we'll go to quickly, I'll just tell you what, hopefully I'll summarize JNC 8 quickly, and then we'll just briefly talk about ACC, AHA. They're not going to actually test you on any controversial topic. They stay away from, and this is a pretty, the targets and everything are still very controversial, but I'm going to try and put you through what they will test you on. So let's go to JNC 8 first. It came out in 2014. Some people thought that it should be called JNC late because it took them 10 years to come up with 2 or 3 recommendations. What they did do was they did not touch the definition of hypertension from JNC 7. They defined stage 1 hypertension as 140 to 159 systolic or 90 to 99 diastolic, and stage 2 more than 160 over 100. Right? They did not touch the definition which has been there since 2003 from JNC 7. They did not touch it at all. What they did was defined targets that pretty much everyone should have a blood pressure less than 140 over 90. So they were like, the magic number should be 140 over 90, but you should be actually okay with a blood pressure of less than 150 over 90 in what they defined as elderly patients, more than 60. And that's the most controversial part of JNC 8, how they defined these folks. Majority of the data which is present actually is okay with this target, but in patients who are more than 80 years old, not more than 60. So they looked at 2 Japanese studies and actually used those studies to make this recommendation of more than 60. The target should be, a little lax. And the other big thing which came out of it was beta blockers became a second-line agent. Right? They're like, if there's no compelling indication, you shouldn't be using beta blockers as a first-line agent for hypertension. And I'm going to summarize even more further. So what they said was, and these recommendations are very similar to the ACC, AHA recommendations, which came out in 2017. Everyone should get lifestyle recommendation. But JNC 8 said, if you have a patient who comes in with hypertension and you're actually seeing that patient, the first thing which you should look at is if the patient has CKD or no. So you have a patient who's actually sitting in front of you. You got to make a decision. Does this patient have CKD or no CKD? If the patient has CKD, the first choice is ACE and ARB. right? So the first question is, does this patient have CKD? Yes, you either get ACE inhibitors or ARBs. If you don't have CKD, then you look at the race, right? And if you are black, you should be starting either thiazide diuretics or calcium channel blockers. Whereas if you're non-black, you can start anything but beta blockers, right? We already told you that beta blockers became a second-line agent. So you're like, you can pick your choice. You can either pick ACE, you can pick thiazide diuretics, you can pick calcium channel blockers if you're non-black. But if you're black, you should choose between thiazide or calcium channel blockers. So it was a race-specific recommendation, and this is based on data that ACE and ARBs might not be as effective in the black population. Does that make sense? So first, you're sitting in front of me. I'm like, oh, you have CKD. Of course, I'm going to start either ACE or ARB. If you don't have CKD, if you're Caucasian, I can pick any of the 3 agents other than beta blockers. But if you are black, then I'm going to pick between calcium channel or thiazide. That actually was JNC8. There was nothing else. So 2 slides and the JNC8 is done. So that's why people said, it took a long time for those recommendations too. Now, in 2017, ACC-AHA recommendations came out, and they were like, they had already, when JNC8 came out, they were like, we don't believe in those recommendations, and there was a lot of political, like each and every journal had like pros and cons, and actually ACC and AHA dissociated themselves from the JNC8 recommendations. Like they didn't even believe in it. So they came in with their own recommendation, and these recommendations were very, 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 very heavily influenced by one study, SPRINT. And they said, well, the blood pressure, normal blood pressure should be less than 120/80, and they started defining stage 1 hypertension as 130 to 139 and 80 to 90. So stage 1 became 130 to 139, 80 to 90 diastolic, and more than 140/90, which was the definition of stage 1 in JNC8, now became stage 2 hypertension, right? They are not going to actually focus on these, but this is just you still got to know. And if you look at if you just broadly look at and just forget about what I've written there, the major thing which is going to actually stand out is the difference between JNC8 and this is what? JNC8 was saying everyone below 140/90. They're saying everyone below 130/80. Okay, very, 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 very heavily influenced by SPRINT. And look at that. Here, they are even for patients who are more than 65, they're saying the target should still be less than 130. And again, this is based on SPRINT study. The SPRINT study actually was less than 120/80. And these guidelines said 120/80 shouldn't be the target. It should be 130/80, because if you see how SPRINT checked their blood pressures, none of you check the blood pressures the way they did it. I'm like, oh, you bring them in, put them in a quiet room, 5 minutes of rest, 3 readings. Who does it? So I think it was a study setting, and they kind of realized that it's just not possible to check the blood pressures they were checking. So they were actually getting much lower numbers, and if we started getting all our patients to less than 120/80 based on our readings, we'll be creating a lot of falls and a lot of other problems. So you gotta actually sometimes go back and look at, some of the minor details to see the problems with how to actually put these recommendations into place. So ACC-AHA also said they came out with some compelling indications. They brought back beta blockers and ACE and ARBs as first-line agents if you have compelling indications like stable ischemic heart disease. And of course, they stood with, if you have chronic kidney disease, you should still use ACE or ARBs. Hypertension in the elderly, just a quick point. JNC defined these folks as more than 60 years old, and they said, well, the treatment should be started only if the blood pressure is more than 150/90. There was a lot of controversy, and I think it's still very controversial because the data was not there to make this recommendation. If they had recommended this age to be 80 years, I think it still would be okay, but there was not much data. Whereas now the new recommendations from AAHA, ACC is that for patients who are more than 65, who are non-institutionalized and community dwelling, the goal systolic blood pressure should still be less than 130. So I think this is a more reasonable definition, but in reality, if somebody's blood pressure is between 130 and 40, they're asymptomatic, they're 75-year-old, I'm not going to bring that below 130. So it's still your individualized clinical judgment rather than, targeted therapy, because it's just one study. Antihypertensive diuretics, chlorthalidone is recommended over hydrochlorothiazide because chlorthalidone is longer acting. And again, if you have heart failure and chronic kidney disease, loop diuretics should be used. Because if your creatinine is 1.8 or 2.0, thiazide diuretics in the doses which we use are not even going to reach where they need to work. So you got to switch it to loop diuretics. And if you're using loop diuretics, they should at least be used twice a day, right? Because the half-life is 4 to 6 hours. And if you just use it once a day, you're not going to be doing much. And when you're using it twice a day, my recommendation would be to use it 1 in the morning and the second dose at 3 o'clock in the afternoon or 4 o'clock, because if you just say twice a day, they're going to be up all night and they're not going to come back to you. ACE and ARB, do not use them together. There's a very high risk of acute kidney injury if you use these two drugs together. Actually, there was a study on Target which showed a higher risk of hyperkalemia as well, and there were more actually events on this combination. So there should be no reason to use ACE and ARB together. Previously, we used to, actually nephrologists were the one which were combining ACE and ARB. This was based on a study in Lancet, Corporate study in 2009. Now you can't even find that study because the data was all made up. So it's been retracted. All Lancet states is that this study is retracted because there was a lot of, it was impossible data which they presented. Indicators for secondary hypertension: if you have somebody who suddenly develops high blood pressure or was fine and now the blood pressure is getting worse, this is worsening at a very fast rate. If your onset of blood pressure was when you were very young or more than 65 years old, you should be worried about secondary hypertension. If you have renal or epigastric bruits. But what board loves to test you on is this: hypokalemia with metabolic alkalosis. If you have a patient who is hypertensive and you have this combination, low potassium and metabolic alkalosis, something should be triggered in your brain. What should be triggered in your brain should be, this patient has aldosterone floating around. This patient has aldosterone floating around. Why should it be triggered in your brain that aldosterone is floating around? Because what is high aldosterone going to do? It's going to reabsorb sodium. You're going to actually become volume overloaded and you're going to become hypertensive. But since you're reabsorbing sodium, what becomes to the charge on the urinary side? It becomes negative. So what comes out? Potassium and H+. So if you're losing potassium in the urine, you become hypokalemic. You're losing H+ in the urine, you develop metabolic alkalosis. So metabolic alkalosis, hypokalemia, hypertension, oh my God, there's aldosterone floating around. At least that should be the first thing which gets triggered in your brain, and we'll come back to it. So before we come back to it, what are the most common causes of hypertension? Secondary hypertension, if you just remember kidney and the adrenal gland, you're done, right? Because Of course, yes, coarctation of aorta can cause secondary hypertension. That's why the first time you see a patient, you should be measuring blood pressure on both the arms and the legs. Only one time. You don't have to repeat it every time, but you gotta do it first time yourself and document it so that you've ruled it out. Because I've diagnosed these patients at the age of 40, coarctation of aorta that late, because nobody had done that. Medications, over-the-counter medications like Sudafed, herbal medications, and all this needs to be actually ruled out in everyone. And of course, you need to do some screening tests for sleep apnea, screening questions whether you wake up rested after a night's sleep, or your normal questionnaire. So sleep apnea, over-the-counter medications, and this should be checked at least in everyone the first time. After that, all you're left with is kidney and the adrenal gland, right? What can go in the kidney? If you have chronic kidney disease, you can't get rid of salt and water normally. So chronic kidney disease is one of the most common causes of secondary hypertension, right? Because you have kidney disease, you can't get rid of salt and water, you're going to become hypertensive. In the kidney, you can actually also have what? Renal artery stenosis. And again, if it's a young patient, you should, be worried about what? Fibromuscular dysplasia. If it's an old patient and you have Doppler findings consistent with renal artery stenosis, it's most likely what? Atherosclerotic. And in the adrenal gland, you just got to actually know all the layers of the adrenal gland, right? Again, this is med school days, if the cortex of the adrenal gland is what? GFR, right? GFR. And the outermost layer is glomerulosa, second one is fasciculata, third one is reticularis, and then there's the medulla of the adrenal gland. And if you remember, as you go in, things become sweeter, right? So it's salt. So what is G? Glomerulosa is aldosterone. Fasciculata is what? Cortisol. It's getting from salt to cortisol. We won't go to reticularis. It's sex hormones. It doesn't cause hypertension. And then in the center is medulla. So if there's a tumor in the outer layer, which is primary hyperaldo, you're going to actually have secondary hypertension. If you have a tumor or anything which is causing increased cortisol from fasciculata, Cushing syndrome, you're going to actually have what? Exactly the same findings. And then a tumor in the medulla, pheochromocytoma, right? G, F, and medulla cause hypertension. That's all what you need to remember. And of course, yes, thyroid disorders can cause hypertension, but these are not diagnostic mysteries. By the time you have hypertension related to these disorders, all the signs and symptoms are already there. Okay, what I told you was they love this. Board loves to test you on a combination of hypertension, hypokalemia, and alkalosis. So going back, if you have a patient with low potassium, let's say I come into your office and my potassium is 2.8, very low, right? What should you be checking first? You should be checking, of course, you'll be taking your history, physical, and trying to figure out what's causing that hypokalemia. But if you were just doing lab test, if you did my urine potassium, if you checked a urine potassium on me, what should it be if I'm, let's say, having diarrhea? Your kidneys are very smart organs, right? I've got low serum potassium. What should my kidneys doing? They should be holding on to all the potassium. So if my urine potassium is low, it's either diarrhea or I'm not eating enough, which is very uncommon, right? Unless you've got anorexia nervosa or something like that. Or you're not eating much at all, tea and toast diet, right? But if my urine potassium is high, more than 20 milliequivalents, that means I'm losing potassium in the kidney. My kidneys are not doing what they are supposed to do. right? My serum potassium is low, but I'm still losing potassium in the kidney. As soon as you see that, you should be looking at two things: blood pressure and volume status. If the blood pressure is normal or low, you gotta check acid base. Just follow this and you're not gonna get things wrong. So if you check acid base and if the patient is acidotic, then you should be worried about what? Type 1 and type 2 renal tubular acidosis. We talked about both proximal and distal have what? Hypokalemia. If you have alkalosis, then you should be worried about either I'm giving you a lot of diuretics, or you're having vomiting, or you're actually inducing vomiting. Don't remember, again, probably in USMLE, probably 20, 25 years back, you were tested on Barter's and Gittelman syndrome, which are nothing but actually, Barter's is a genetic mutation, as if somebody is taking a loop diuretic like furosemide, and Gittelman's is actually a mutation in the same channel as if somebody is taking a thiazide diuretic. Yeah, it's exactly the same channels, but it's a genetic mutation rather than a use of diuretic. So it looks exactly similar to as if somebody is taking a diuretic, right? But they're not taking diuretics, right? Now, the main thing which they're going to be tested, they're going to test you on is hypokalemia related to renal losses, but in addition, what are you having? Hypertension and alkalosis. So as soon as you see that, what should you be ordering? Plasma aldosterone and plasma renin activity. As soon as you see that, at least you should check this, right? And this one is very easy. If your plasma aldo is high and renin is low, what is the diagnosis? Most common is primary hyperaldo, a tumor in the aldosterone, in the adrenal gland, which is secreting aldosterone, right? Because it's a tumor, right? Tumor is secreting aldosterone. What is it going to do? Aldosterone is going to go into the kidney, reabsorb sodium. You're going to become hypertensive and volume overloaded. What is high volume going to do to the renin? Suppress. So high aldo, low renin, what should you be thinking? Primary hyperaldo. What about high renin and high aldo? This is what happens when you have renal artery stenosis, right? So you have renal artery stenosis. What is the kidney thinking? Because now not enough blood is going to this kidney with renal artery stenosis. The kidney is fooled into believing that it's a low volume state because there's not enough blood going to the kidney. And when the kidney thinks it's a low volume state, what does it start secreting? Renin. So renin goes up, aldosterone goes up, and what is aldosterone going to do? It's going to cause alkalosis and hypokalemia, right? But the aldo and renin is going to be high. And the other, situation is if you have low renin and low aldo, it's kind of confusing. I'm like, oh my God, based on hypertension, alkalosis, and hypokalemia, I thought there should be aldosterone floating around, but there's no aldosterone. So in those cases, actually, cortisol is acting like an aldosterone. So in those cases, you should think about, could this patient have Cushing's syndrome? Because cortisol is actually acting like aldosterone. Okay, so if you have no idea about what I'm talking about, that doesn't actually make sense. The bottom line is, when you see a hypertensive patient with hypokalemia and alkalosis, do what? Check a plasma aldosterone level and a plasma renin activity. Okay. They love to test you on primary aldo. So you have this scenario, you check a plasma aldosterone and plasma renin activity. The ratio, if it's higher than 20, it's a screening test that the patient might have primary hyperaldo. So if the ratio is higher than 20, what should you be thinking about? Primary hyperaldo. It's a screening test. Just remember screening tests, that means there'll be a lot of false positives. And one caveat, maybe you should write, when I'm talking about a ratio of PAC to PRA more than 20, the plasma aldosterone level has to be higher than 15 as well. So it can't be a plasma aldo of 5 and a plasma renin activity of 0.1, 5 divided by 0.1 is 50. It's like, oh, the ratio is high. But that doesn't count unless the plasma aldosterone level is higher than 15. So it's a screening test. So the biggest mistake they want you to avoid is that if somebody has a positive screening test, don't go straight away to a CT scan. Because even though the screening test is positive, it could be a lot of false positives. So you got to do a confirmatory test. And endocrine, I tell everyone, is so easy, right? If something is high, you want to suppress it. If something is low, you want to stimulate it, right? Look at each and every test. Each and every test is based on the same, right? If something is high, you want to try and suppress it. If something is low, you want to stimulate it. And here, what are you trying, you are assuming that the patient has hyperaldo. That means it's an aldosterone secreting tumor. I want to try and suppress it. Right? If I can't suppress it, I know it's a tumor. Right? How can I suppress aldosterone? Aldosterone is under the control of volume. So I tell my patients, this is the last time your physician is going to tell you go and have fun with Burger King diets on Saturday and Sunday. Eat as much salt as you can. So if I asked you to eat a lot of salt on Saturday and Sunday and then I checked your urinary aldosterone, what should happen to your urinary aldosterone? Should go low. But if you have a tumor, is tumor under the control of anything? No. So if you can't suppress it, I've confirmed it, then you actually do what? CT with adrenal cuts. So you have to tell the radiologist to actually go through that you're looking for an adenoma, because then they'll do very thin slices to the adrenal gland to see if there's an adenoma or no. If the patient is young and you find an adenoma, you can send them to surgery. If the patient is older or there's bilateral lesions, then you actually have to do adrenal vein sampling to see where exactly the aldosterone is coming from so that you don't take the wrong adrenal gland out. Right? And this is only, adrenal vein sampling is not very easy to do. You got to actually send them to a center where they are used to doing these procedures, because this is hard to cannulate the adrenal vein. A 22-year-old woman referred from GYN for blood pressure evaluation. These are the blood pressures, and these are the labs. I'm going to let you read it. Which of the following is the most important or appropriate next step in her management? Awesome. Now, based on the last question, which of the following is the most likely diagnosis if both PRA and plasma aldosterone level returned very high? Great. So it is, plasma renin and plasma aldosterone came back very high. So it could be either renal artery stenosis or fibromuscular dysplasia, right? But this was a 22-year-old woman, right? No, this was not a 60-year-old with atherosclerosis, diabetes, hypertension. So here you have to use your clinical judgment that what is the likelihood of this patient having atherosclerotic renal artery stenosis? Very low. So the most likely answer is fibromuscular. And with Conn syndrome or adrenal adenoma, what should happen to the plasma aldosterone? It should be high. What should happen to the plasma renin activity? It should be suppressed. Make sense? Okay. Switching gears. Hypernatremia and hypernatremia. So one basic thing which you need to know about is your plasma osmolality. This is the formula, right? But the majority of the contribution of plasma osmolality comes from what? Sodium concentration. And if you look at the sodium, this bracket tells you that it's the concentration, is not the total sodium level. It's the concentration of sodium. And hypernatremia is defined as a serum concentration of more than 145, whereas hypernatremia is less than 135. Since this is a concentration, any problem, or majority, 90 to 95% of the problems with hypernatremia and hyponatremia are problems of water homeostasis. It's a problem of water, not a problem of sodium, right? So if your water level is too high in your blood, what's going to happen to the serum sodium concentration? It's going to go low. If your water is low, what is going to happen to your serum sodium concentration? Is going to go high. Okay. So I'm going to just quickly, because this is very easy, and these are 2 or 3 simple questions which are going to actually be giveaways on the boards, right? So but if you still got to understand the concept. So let's say somebody actually asks you to, go to Mexico, and to cleanse your toxins, you got to actually drink a lot of water. Like just start drinking a lot of water. Like rather than 2 or 3 or 3 or 4 liters, start drinking about 7 to 8 liters of water. What's going to happen? You're going to drink a lot of water. What's going to happen to your serum sodium concentration? It's going to start coming down. Serum sodium concentration is the main concentration which controls the plasma osmolality, which I told you, right? So your plasma osmolality is going to go down close to low normal. And as soon as your plasma osmolality goes anywhere close to the low normal end, what happens to the ADH? ADH shuts down. As soon as your plasma osmolality comes down to the lower level, it totally shuts down. So if the ADH shuts down, what is going to happen? You can't reabsorb water, right? Because your kidney is going to try and get rid of that water. What kind of urine are you going to be passing out? Concentrated or dilute? Very dilute. And what's the most dilute urine you can make? 50 to 75 milliosmoles. So just remember 50. You can't pee out pure tap water with nothing. It has to have some solute, right? And the lowest is 50. And, you'll actually get rid of the water, and you'll maintain a normal plasma osmolality. If you start drinking a lot of water, that's what you'll see, right? You start peeing out very, almost like tap water kind of a urine, right? Because your body doesn't need that extra water, it's going to actually get rid of it. On the other hand, if I take you to a desert, and I'm like, I'm going to torture you, no water for you. So I check your serum sodium right now, it's 138. 2 hours later, what's going to happen? You're sweating away to glory. Your sodium is going to go up to 141. Let's say 6 hours later, 8 hours later, what's going to happen to your serum sodium? It's going to be 145. And 145 means the plasma osmolality is going to be roughly 2 times sodium, right? So about higher limit of normal. What happens when when this situation happens? 2 things happen. Your ADH is going to be working full time. It's going to be acting like crazy. But even prior to that, what happens is thirst. You are going to be fighting with me for water. This is the biggest torture you can do to anyone, right? And we do it all the time in the hospital, right? Somebody is intubated, wide awake, serum sodium is 145. Poor guy can't ask for water. He's at your mercy. But you're like, oh, you're talking about the case. Vitals are stable and his eyes are like, please feed me, It's totally dependent on you. Yeah, have you? But we never actually reach this stage because we are social drinkers, right? You've got what? Even when you're not thirsty, you're sipping a little bit of water. We never let our serum sodium even come close to 145 because we are social drinkers, right? But it's just a huge torture. Try doing that. It's just painful. So even when somebody is intubated, I would try and maintain their serum sodiums close to 140 so that they're not actually feeling that intense thirst, but they can't even ask for water, right? But we let that happen quite often in the hospitals. So what happens is, as soon as your serum osmolality goes close to 290 to 95, you'll be very thirsty. You'll fix it. You'll go and reach for water. And the second thing which happens is plasma ADH is going to be really, really high, and you're going to be peeing out very concentrated urine. And what's the most concentrated urine you can make? 1,200 milliosmoles. So a 30-year-old gentleman can make a urine osmolality of 1,200 milliosmoles. But as you age, your concentrating ability goes down. So if when I was 20, my urine osmolality could go up to 1,200. By the time I'm 60, 70, 80, my urine osmolality can't go more than 550, 600. And that's why a lot of people actually get up at night to pee. It's not all BPH. Right? Of like, oh, you probably have prostate problem. No, you can't concentrate your urine very effectively. So if you drink water late at night, you actually have to get up at night to pee because you're not able to concentrate. Right? And you normalize by thirst and by retaining all the water possible, you retain it. So now I'm going to tell you, because the board's favorite question is SIADH, syndrome of inappropriate diuretic hormone secretion. But how are you going to diagnose inappropriate diuretic hormone secretion if you don't even know what's appropriate, right? To know inappropriate, you need to know what is appropriate, right? So the one thing I already told you, what is appropriate secretion of ADH? If you were in a desert and your serum osmolality was what? 290, 295. It's appropriate, the ADH is secreted because it wants to retain all the water. We also talked about, when we were talking about pre-renal AKI, if you are hypoperfusing or hypotensive, which three hormones get activated? Sympathetic, renin-angiotensin, and ADH. So it is appropriate, if you're hypovolemic, hypotensive, that ADH should be secreted. And of course, nausea and pain can actually cause this. These are one of the biggest, stimulators of ADH. We don't understand how, but they stimulate ADH quite a bit. But I want to just tell you one thing to make things easy. So I told you plasma osmolality is going to cause ADH release if your serum osmolality is high or if your volume is low. But again, if there is a competition or war between plasma osmolality and hypovolemia, what wins? Hypovolemia wins. And I'll tell you why. As we evolved, what is more important for you or your body, to maintain a normal plasma osmolality or to maintain a normal volume? To maintain a normal volume, because it's so anytime if there's conflicting signals going to the ADH, volume always wins. If your volume is low, your body doesn't care about the osmolality. It's going to keep on secreting ADH. Right? Volume always wins over osmolality, and hopefully it's going to be very clear. So how does hyponatremia develop? I told you hyponatremia develops from what? If you're drinking a lot of water, which is very, very, very uncommon, like you have to drink more than 12 or 13 liters of water to develop that. Majority of the time, the problem is excretion of water. That means you're drinking water, but you can't get rid of water. How do you get rid of water? From your kidneys, right? And what impedes water excretion is ADH. So if I'm drinking a lot of water, but my ADH level is very high, all the water which I'm drinking is going to be reabsorbed back, and I'm going to become hyponatremic, right? Because I'm drinking water, but I can't get rid of water because ADH is floating around. It's going to cause hyponatremia. So just a quick, and we'll summarize this too. So anytime on the exam you have a patient with hyponatremia, so what are you going to do first? You start with the serum sodium of 128. The first thing which you should be looking at is, let me check a plasma osmolality. I want to check a plasma osmolality because what the boards is more interested in is what? Low serum sodium and low plasma osmolality. Right? That's what the board is interested in. Because if the plasma osmolality is high, the answer is very clear that it is related to probably hyperglycemia. If the plasma osmolality comes back normal, probably it's a pseudo hyponatremia. It's just a lab error from either a paraproteinemia or hyperlipidemia. It's a lab error. That a patient might have multiple myeloma or the lipid levels could be high. So what you're really interested in is low serum sodium and low plasma osmolality. After that, the next step should be to check what? A volume status. How do you check a volume status? Clinical, 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 right? If you're volume depleted, they'll give you that there's no JVD, the patient is orthostatic. If they want to give you that the patient is volume overloaded, they'll give you S3 gallop, they'll give you crackles on the lung exam, pedal edema, and you can also use what? You can use some objective assessments like urine sodium, fractional excretion of sodium, and fractional excretion of urea. Now, the third part, and it'll all make sense when we look at the table next time, is you also need to check whether the ADH is present or no. Most of the time, ADH is very difficult to measure. So rather than measuring an ADH, what do? Is we check urine osmolality. If the urine osmolality is 200, 300, 400, 500, that means there's ADH floating around. Because if there was no ADH, what should the urine osmolality be? 50 or 75, very low, right? High urine osmolality tells you that there's ADH floating around. Okay. Now, we already talked about this. So you have a patient with hyponatremia. What is the first thing which you're going to check? Plasma osmolality. What we are interested in is low plasma osmolality. As soon as you have low plasma osmolality, you should be checking what? The volume status. Either hypervolemic, hypovolemic, or euvolemic. Hypervolemic is very easy, right? S3 gallop, JVD, crackles, pedal edema, and the diagnosis is what? Cirrhosis, nephrosis, cardiosis, right? All these OSIS. Done. It's clinical. They'll give you all the clinical signs. Hypovolemia should be, again, of course, orthostatic hypotension, orthostatic blood pressures, and this should be very, very simple. They're not very interested in this. They're interested in euvolemic, and they love SIADH, right? So how would you separate SIADH and psychogenic polydipsia? And everyone is becoming very sensitive, so nobody likes psychogenic polydipsia now. They call it obsessive compulsive water drinking. That's fine. So how would you separate, somebody who just, thinks that they have to cleanse their toxins and drink 15 liters of water every day, and that's what is causing the hyponatremia? How would you differentiate that? What is the urine osmolality going to be in the patient? Like, if I start drinking 12 liters of water, what's going to happen to my ADH? It's going to shut down. What is my urine osmolality going to be? 50 to 75. That is going to be obsessive compulsive water drinking. Whereas if you check my urine osmolality and my urine osmolality is 300, 400, that means it's inappropriate ADH. Why is it inappropriate? Because if the patient was hypovolemic or hypervolemic, it's the volume which is driving the ADH. So in this case and this case, it's appropriate ADH release. But if the volume is normal, there should be no ADH floating around. I'm just going to give you a quick example. What about the Boston marathoners? How do they get actually hyponatremia? So I am running, right? As I'm running, I become a little volume depleted. If I'm volume depleted, what gets secreted? Renin-angiotensin is upregulated, and what else? ADH. So now, as I'm running, my ADH is very high, and as I'm running, what are people actually giving me? Pure water. So now I'm running with a high ADH, and you're giving me a lot of water. All the water I'm going to drink, can I get rid of it? By the time I reach the end, and if I've had about 3 or 4 liters of water, which I can't get rid of, what's going to happen? I'm going to have a seizure. Right? Does it make sense? So SIDH is, I'm going to switch to SIDH because this is what they're going to test you on. Low serum osmolality, low sodium concentration, of course, right? Low serum sodium, low plasma osmolality. You check a volume status, the patient is euvolemic. If I check a urine osmolality, what is it going to be? High, because there's ADH floating around. And the only problem here is, how do I know that, let's say me and you are arguing. You're telling me that the patient is euvolemic, and I'm like, no, I don't think your exam is that great. The patient is hypovolemic. How are we going to break that? That's why the urine sodium has to be more than 20, because if the urine sodium is less than 20, I win. Maybe, the patient is hypovolemic. Because if the patient is hypovolemic, I cannot call it inappropriate ADH release, right? Because if the patient is hypovolemic, volume trumps everything. So it's the volume which is driving the ADH release. So by checking a urine sodium and making sure that it is not less than 20, I'm objectively confirming that the patient is not hypovolemic. And all the time, you got to actually rule out cortisol and thyroid hypothyroidism, because both cortisol deficiency and thyroid disease can release ADH, and it looks exactly like SIDH. So before you make a diagnosis of SIDH, make sure that the patient doesn't have cortisol deficiency or hypothyroidism, because it's very hard to differentiate these conditions. What causes SIDH or inappropriate release of ADH? I would just say anything in the brain, anything in the lungs, and psychotropic drugs. So if you just remember, it could be anything in the brain, anything in the lungs, and drugs like SSRIs, SNRIs, atypical antipsychotics, phenothiazines, any of these drugs which act on the brain. And then you got to remember anything in the lung, anything in the brain. And the classical one in the lung is small cell cancer, but it could be anything, actually. Even Legionella pneumonias, anything in the lung can actually do it. Prudent approach to the treatment, they're not going to ask you about the specifics, but what they want you to know is, if you have acute symptomatic hyponatremia of short duration, the risk of cerebral edema is very high, so you got to actually fix it very soon. So for Boston marathoners, you don't even need a physician. EMTs can give you 1 milliliter per kilogram of hypertonic saline on the ground without anyone's permission. So if you are 60 kgs, you fall down while running a marathon, having seizures, you will be given 50 to 60 cc's of hypertonic saline. So don't be afraid of it. If they can do it, you can do it too. If you have chronic hyponatremia or unknown duration, be slow and steady. Don't overrun the target of increasing the serum sodium by more than 8 to 10 milliequivalents per day. Long-term therapy is restriction of fluid restriction. Nobody uses dimeclocycline, and V2 receptor antagonists, which actually antagonize ADH or acuritics, are very expensive, and most of the time I've used it very, very, very rarely in about 5 or 6 patients, but most of the time with fluid restriction and other means, you can actually control it. Points to remember in evaluating patients with hyponatremia: first, determine the osmolality. If the patient is hyposmolar, check a volume status, and then the differential diagnosis depends on volume status. They love SIADH. This is very easy. Hypernatremia is the easiest thing you'll ever diagnose. If the serum sodium is 146, what should your kidney be doing? What should the ADH be? What should your ADH be doing if your serum sodium, if I took you to a desert and don't let you drink water and your serum sodium goes to 145, ADH should be like, serum sodium is high. You want to be secreting a lot of ADH because you want to hold on to the water as much as possible. So if you're actually not able to drink water and I'm actually taking the access of water away, what should your urine osmolality be? Very, very high, right? So if you see a patient with serum sodium of 145, 146, and the urine osmolality is 800,000, the problem is what? Access to water. That's, this person can't actually drink water, can't access water, right? That's why you see this more commonly in very young or very elderly, right? If somebody is in a nursing home and has a hip fracture and the water is sitting right there and my bed is there, I'm thirsty, I can't get to the water, what's going to happen slowly? I'm going to become hypernatremic. I'm thirsty, but then I get confused. I can't even ask for water, right? So it's access to water is a problem if your urine osmolality is high. If your urine osmolality is low, you have what? DI, right? So what's the easiest test to do if somebody is hypernatremic? Check a urine osmolality. If the urine osmolality is high, it's access to water. Very, 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 very rarely it could be a stroke in the hypothalamus where your thirst receptors are gone. Very uncommon. You don't even need to know. If urine osmolality is low, it's either central or nephrogenic DI. Central DI is what? If there's some problem in your brain where the hypothalamic pituitary axis, there's a tumor, infiltration, surgery, cerebrovascular accident where there's no ADH being released. So these patients will respond to ADH administration. And the ADH which we give them is what? Desmopressin. So these folks, if I give them desmopressin, what is going to happen to your urine osmolality? It will increase. Whereas if it is nephrogenic, if I give them desmopressin, will they respond? No, because the problem is in the kidney, and the most common cause of nephrogenic DI is lithium. Actually, it can also happen with Sjogren's syndrome too. Again, they love Sjogren's, right? So I have to keep on pointing it out. Treatment for nephrogenic DI actually is very interesting, that is thiazide diuretics, because thiazide diuretics cause a little volume depletion, and if you cause a little volume depletion, majority of the water is actually reabsorbed in the proximal tubules then. So the water doesn't even come to the distal tubules where ADH has to act. So it's this kind of sounds a little odd, but the treatment is, in this case, thiazide diuretics. And in the central, you just give them ADH, which is desmopressin. So a quick word about polyuria. Polyuria is defined as a urine output of more than 3 liters per day. So as soon as you see a patient with 3 liters, if somebody is peeing out 5 liters, we get a consult. I'm like, oh, does this patient have diabetes insipidus, right? But most of the time, what is the cause of polyuria? If I give you 5 liters of normal saline, what are you going to pee out? You're going to pee out 5 liters. If I give you 300 cc's of normal saline per hour, you don't need it. You're going to pee it out. So the most common cause is if I'm giving you normal saline or a huge amount of solute. So Anytime you have a patient with urine output of more than 3 liters per day, check a urine osmolality. If it is higher than 300, it is because you are giving this patient a lot of solute. It's like normal saline or parenteral nutrition. If the urine osmolality is less than 250, check whether this patient is drinking a lot of water. If your serum sodium is less than 137, is psychogenic polydipsia. If the serum sodium is more than 142, you should be worried about DI. Okay. A 76-year-old male smoker, admitted with 3 weeks of falling and dizziness, lost 20 pounds in the past 6 months. Exam shows blood pressure of 120/80, heart rate is 85. These are the labs. Sodium is 116. What do you check next if you have a low serum sodium? Plasma osmolality. It is low. Urine sodium is 25. Urine osmolality is 673. TSH is normal. Cortisol is normal. Which of the following is the most likely diagnosis? Great. So the patient was, they will very clearly give you a euvolemic patient. They won't give you JVD, they won't give you edema, they won't give you orthostatic. They will make sure that they tell you that there's no problem with the volume, right? And what were the other clues? This urine osmolality was high. That means ADH was present. Why should ADH be present if there's no volume issue and the serum osmolality is low? So that is why it's inappropriate. And how did I make sure that the patient was not volume depleted? What was the urine sodium? Greater than 20. If this urine sodium was 10, maybe I need to go and do an exam again. Okay? In SIDH, what would you expect? High urine osmolality and high urine sodium, or any of those two? So think about it, because this is where awesome. So high urine osmolality because ADH is present, and urine sodium will be higher than 20, because if the urine sodium is less than 20, you cannot call it syndrome of inappropriate ADH, because if you're volume depleted, ADH is going to be secreted. It is appropriate. Make sense? Okay. This is very, just key points. We've already talked about this, so I'm not going to go over again. Please look this for hypokalemia. Majority of the questions are going to be, if you understand this chart and how we go about it, majority of the low potassium questions are going to be really, 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 really easy. Why do we care about hypokalemia, especially in management of acute myocardial infarction? There's huge amount of data that there's a 2 times increased risk of VFib when potassium is less than 3.6. And especially if you have an AMI, recommendation is to keep potassium more than 4 and magnesium more than 2. The main worry with acute myocardial infarction and potassium is that you have injured myocardial cell, and when you have an MI, there's huge amount of epinephrines floating around from sympathetic system too. And if you have huge amount of catecholamines which are floating around, they push the potassium inside the cell. And so you are at a higher risk of hypokalemia just because of catecholamines, and then you have irritated heart muscle, which creates a pretty good ground for arrhythmia. So that's why in cardiovascular units, you'll see some of these basic orders. Hyperkalemia is really easy if you follow this diagram. So anything which causes a problem with renin, angiotensin, aldosterone system is going to cause what? Hyperkalemia, because ultimately, if the aldosterone is low, can you get rid of potassium? Because aldosterone is something which reabsorbs sodium and gets rid of potassium. So if there's a problem anywhere from renin to angiotensin to aldosterone, you're going to have hyperkalemia. What can decrease the renin? Diabetes, right, from autonomic neuropathy, and there are certain drugs like NSAIDs and beta blockers which can decrease the renin levels. Let's say the renin levels are fine. Renin is going to actually convert angiotensin 1 to angiotensin 2. What stops this conversion is ACE inhibitors. So ACE inhibitors, that's why it can cause hyperkalemia. Let's say that's not a problem. Angiotensin 2 acts on the angiotensin receptors. But what if I'm blocking the angiotensin receptors by ARBs? That can cause it. What about adrenal gland? If there's adrenal insufficiency, you can't make adrenal gland, you're going to have hyperkalemia. Maybe let's say the adrenal gland is fine, but in the adrenal gland, there's an enzyme called aldosterone synthase, which makes the aldosterone enzyme, right? What can block that? Actually, heparin and all the azoles, ketoconazole, fluconazole, all of them can actually block that enzyme, so they can contribute to hyperkalemia. Let's say adrenal gland is fine, that enzyme is fine. Now, aldosterone acts on the aldosterone receptor. What can block that? Spironolactone, eplerenone, and all these drugs, right? These new ones. That's going to cause hyperkalemia. Let's say even that is fine. What does aldosterone do? It increases the sodium reabsorption, right? So if I block the sodium channel, I can't get rid of the potassium. So what blocks the sodium channel? Amiloride, trimetrin, and drugs like Bactrim and pentamidine. So if you block the sodium channel, you can't actually get rid of potassium because sodium has to go in to create a negative charge for potassium to come out. So if you follow this from renin down to the sodium channel, you'll figure out all the causes of hyperkalemia, right? Be systematic and you don't have to memorize. What happens with acute hyperkalemia, peak T waves, widened QRS, and ultimately, you can actually go into torsades. Treatment is urgent if the potassium is more than 7. You should be worried about if the potassium is more than 6. The first thing is to do cardioprotection. And what do? Of course, you'll put the ECG on and you'll continue to give them calcium gluconate till you see right in front of your eyes the QRS complex going back to normal. Everyone gets excited about calcium gluconate when somebody is hyperkalemic, but you gotta give it over 60 seconds to 2 minutes because if you give calcium gluconate too fast, you're gonna make them puke. So even though everyone is excited, the push should still be slow, and you can keep on repeating it till the abnormalities go back to normal right in front of your eyes. While you're buying time, give them D50 and insulin. Bicarb is not very helpful, and if you're using albuterol, it should be 4 times the dose which you use for your COPD patients. It's not 2.5 milligrams. It's 10 milligrams to actually have an effect. So I know it's the right dose if I see tremors, right? So that's the right dose. So the respiratory therapists are going to question you. I'm like, are you crazy? Why? I'm like, then you have to tell them your indication is not bronchospasm. You're trying to actually decrease the potassium levels. And of course, there are newer agents and Caxylate, which is now coming. There's a lot of questions being raised how effective it is. Hypercalcemia. This will be covered in endocrine too, but the main thing with hypercalcemia is you got to know what is the first test you're going to order. If you have a serum calcium which is 14, the first test which you should order is what? PTH. That's what they want to test you on. So if your calcium is high and if your PTH is low, there's only 3 things, right? Either there's malignancy or there's granulomatous disorders like fungal infections or ANCA-associated disorders, or somebody is taking a lot of calcium. It used to be milk alkali syndrome. Now it's this like huge doses of mega doses of vitamin D along with calcium, right? 50,000 units sometimes, rather than every week. Some people have taken it every day along with calcium, and after about 10 days, you're coming in with, right? So it's either malignancy or granulomatous disease or milk alkali. And in malignancy, you can actually see majority of them are through PTH-related peptide, like solid tumors. Some of them are related to direct effect on the bones, like multiple myeloma, IL-6 releases it. And some of them are the same mechanisms like granulomatous disease, which is 25-hydroxy vitamin D being converted into 125. So granulomas and lymphomas convert 25 into 125, and that's what causes hypercalcemia. But in all of these, PTH is going to be low. If your PTH is high, the board wants you to know two things in your differential. Either it's primary hyperpara or a benign, relatively benign condition called FHH. So if your PTH is high, either it's primary hyperpara or FHH. With primary hyperpara, you'll get bone stones, bone groans, everything, right? But whereas FHH is going to be familial disorder, everyone in the family had slightly higher calciums, and the major differentiating feature is going to be what? This. FHH will have low urine calcium. So that's why if you're, before you call somebody is having primary hyperpara, you should be checking what? Urine calcium. If the urine calcium is low, most likely what is it? FHH. Leave it alone, right? And what happens in hyperpara? There's high calcium, low phosphorus, and the PTH is going to be high. Just remember, in primary hyperpara, a normal, if you have a calcium of 13, and if your PTH is in the normal range, it is actually high, right? Because PTH should be suppressed. A normal PTH in a patient with hypercalcemia is what? It is high. Make sense? Because PTH should be suppressed if you're hypercalcemic. Okay. So FHH, we've already talked about. You gotta know that these patients are hypocalciuric, low calcium, whereas in primary hyperpara, the patients are hypercalciuric. That's why they form calcium oxalate stones. Okay. Primary versus secondary hyperpara is pretty easy. Primary hyperpara is going to be what? Increased PTH, high calcium, low phosphorus, whereas secondary hyperpara, the calcium is actually going to be what? Low or normal, and what is going to be the main abnormality with secondary hyperpara? Phosphorus is driving the problem, right? Phosphorus is going to be high. This is what you see in majority of the patients with chronic kidney disease. Calcium is low normal, phosphorus is high. Hyperphosphatemia, secondary due to CKD. Calcium management, all you need to remember with calcium management is first treatment is what? IV saline, IV saline, IV saline, and the second one is bisphosphonates. That's all they want you to know. First is IV saline. Loop diuretics are out unless you're volume overloaded. We used to do, give normal saline and furosemide. But use furosemide only if somebody is volume overloaded. Otherwise, it's just saline. 55-year-old female, past medical history, squamous cell cancer 2 years ago, doing fine, exam is normal, calcium is high. Calcium previously was 9 to 10, phosphorus is 2.1, and PTH is 108. Which of the following is the most likely cause of her hypercalcemia? This is actually primary hyperpara. I had given you the history of cancer just to confuse you. But again, if it was hypercalcemia of malignancy, what should the PTH be? Very, very, very low. These patients, anyone with cancer can still have primary hyperpara. So don't get, think logically. What is the first test to do? If you have high calcium, look at the PTH. Hypomagnesemia, just a quick point that the most common cause is now becoming, it used to be alcohol abuse and probably is still, but chronic use of PPI can actually cause hypomagnesemia too. So if you have a patient who you can't figure out why the patient is hypomagnesemic, think about discontinuing PPIs. A few slides on CKD. I'll just, what is CKD is structural and functional kidney abnormalities for 3 months at least. So you have to have low GFR for at least 3 months to call it chronic kidney disease. If you look at this, GFR is low in stage 2, 3, 4, and 5. Stage 1 chronic kidney disease is actually your GFR is normal, but you might have polycystic kidney disease, or you might have proteinuria with normal GFR, so that will be counted as chronic kidney disease stage 1. And rest is all dependent on GFRs. They want you to realize that the biggest mortality in CKD is not related to kidney disease, it's related to heart disease and cardiovascular risk. The risk is really, really high, so you actually treat them very, very aggressively with all the same stuff which you would use for your high-risk cardiovascular patients. How do you manage it? All of them should be on ACE and ARB if they have hypertension or if they have proteinuria more than 1 gram. Do not use ACE and ARB together. Blood pressure goal with CKD now is 130/80. You should maintain their bicarb above 22 milliequivalents per liter, because now there's good evidence that if you don't treat the acidosis, the decline in kidney function is faster. We used to correct the acidosis just to protect the bones previously. But now there's evidence that if you correct the acidosis, you can actually slow the decline of kidney function. We've already talked about secondary hyperpara. The problem in kidney disease is you can't get rid of phosphorus, right? You eat phosphorus in your diet, you can't get rid of it, it drives the PTH up. On the other hand, kidney is the main organ where 25 hydroxy vitamin D is converted into 125. If you can't convert 25 into 125, low vitamin D is also going to drive the PTH. So how do you treat it? The first thing is control the phosphorus by giving phosphate binding agents. And after you've controlled the phosphorus, you should start 125. And the reason you don't want to start 125 first is what? If I start you on 125 vitamin D, what am I going to do? I'm going to reabsorb calcium and phosphorus from the gut. Your phosphorus is even going to go higher, is going to worsen. So the first thing is to do what? Control the serum phosphorus and then start calcitriol. This is a prescription vitamin D. You can't get it over the counter. What do you do for hyperphosphatemia? Reduce the phosphorus in the diet. Use the phosphate binding agents, which could be calcium-based or non-calcium-based. Put on, these are some of the common agents which we use. And second thing you do is use activated vitamin D or calcitriol. And again, phosphate binding agent should be given with meals because you're trying to bind the phosphate which you're eating. Anemia recommendations, don't actually get the hemoglobin back to normal range. We used to do it 10 years back because a lot of drug companies were pushing it. They were hiding some of the data about high strokes and high cardiovascular mortality. So I generally try and keep the hemoglobin close to 9 to 10 and not even higher than that. There's a risk with gadolinium, which is an MRI contrast agent. There's a disease called nephrogenic systemic fibrosis. It's a pretty serious disease, uncommon, but the recommendations are to avoid the MRI gadolinium contrast for anyone with a GFR less than 30, or if you have acute kidney injury or end-stage kidney disease. Actually, the American College of Radiology recommends it if your GFR is less than 45. Not to use gadolinium at all. I'm not talking about the CT contrast. This is the MRI contrast. And one slide on PKD, and we are done. So this is the most common genetic disease which they're going to test you on. If you look at the kidneys, it's started with cyst. Autosomal dominant is the most common. What they want you to know is that if a patient has polycystic kidney disease and you have an infected cyst, ciprofloxacin or fluoroquinolones are the best agents because they can actually enter the cyst. 40% of PKD patients also have cysts in the livers. And one other big thing they want you to recognize is that if you have polycystic kidney disease, it is associated with cerebral aneurysms. But the point is, do not screen everyone for cerebral aneurysms with an MRA unless the patient has a history of aneurysms in first-degree relative or has a high-risk occupation like a scuba diver or flies jets or is a pilot or something like that. You don't need to screen everyone. But in high-risk professions, of course, yes. And I'm going to end here. Thank you for your attention.